and a very warm welcome on this Sunday morning for the webinar on Pathways to Progress. With immense pleasure, I would like to invite Dr. Rajat Bajaj, who is Director and Unit Head Medical Oncology at Fortis Hospital, Noida. Over to you, sir, for the welcome and introductory note.
Good morning. Am I audible?
Yes, sir.
Okay. So good morning, everyone. Once again, I thank you all for joining this morning on this webinar to progress. We are going to discuss in the next 2 to 3 hours about what is new and the updates in the field of lung and breast cancer. We all would definitely agree and understand as clinicians that we have to give the best to our patients every morning, every day, and our field is evolving very rapidly. As clinicians, this is a collaborative effort from our side that we involve the brightest minds in oncology to discuss the important topics, the nuances, the updates, so that all of us can be abreast of what is going on in oncology, the latest trends, and give the best to our patients every time when they come to us. So, without any further delay, we are going to start our lung cancer session with a talk on advanced metastatic NSCLC. And to speak about that, we have with us my dear friend, Dr. Vikas Talreja, who is a well known oncologist in India. He is the Director of Medical Oncology at Regency Hospital in Kanpur. Dr. Talreja, good morning. Over to
Very,
you.
very good morning and very warm welcome to everybody. Many thanks to Dr. Rajat Bajaj for awakening us in this sunny morning to get us the latest and the best nuances. And I must say that while going through the slides and the uh, discussion, we were literally amazed as how much the science has progressed and is progressing in terms of the last few World Cancer Lung Cancer Congress, and we are in the next dimension now. So, without further ado, I will ask the host to share the PPTs, and the first slide that I will be discussing will be the Empower Lung 1 trial, where the Semilimab monotherapy for the first line advanced non-small cell lung cancers, specifically with the PD-L1 more than 50% was taken, and 5-year outcomes were studied. So the trial design was similar to the uh, uh, was the keynote trial, where the non-small cell without any actionable mutations were taken, and they were randomized either to the Semilimab monotherapy, 350 milligram every 3 weekly, followed by the continuation of the same, and if it progresses, to add chemotherapy, as compared to the investigator choice of the chemotherapy. And predominantly, the stratification was the histology between squamous and non-squamous, and whether it was Asian or the rest of the world. Next slide. So, in as similar to the Keytruda trial, the Semilimab also performed significantly well in those patients who had a PD-L1 percent. As you could see, the hazard ratio 0.5, meaning a 50% reduced chances of deaths when you give Semilimab as monotherapy in 1 year, and also in the 5-year outcomes in both of independent committee review and the intent to treat analysis. And the PFS also 50% reduction in the chances of progression, with the response rate of doubling from 20% to nearly 40% in all group populations. And you could see that those who performed well in the first year also kept on performing till the 5th year, showing that those who derive benefit as compared to the other immunotherapies do have the similar outcomes in terms of 5 years. And the duration of response was maintained in the PD-L1 positive. Next slide, please. So also, when those who had progression after the Semilimab, the option of adding chemotherapy to the Semilimab was that 2-year, 10% of the patients did had a progression-free survival, and as compared to 0% in the other arm. And the overall survival population at the end of 5 years was nearly 30%. So again, showing that it does have its uh, benefit, and that's where I believe it's going to make a much difference, as those patients who have the similar outcome, probably the cost effective analysis in future is going to play a major role in this molecule, which has similar results, similar performance, and a deeper response and a duration of response lasting more than 5 years. So encouraging responses. Now, next slide was the real world study, which was done, and the subgroup also showed the similar results of the same. And therefore, on those patients who had a PD-L1 uh, positive population, that is anything more than 1%, again showed that semilumab plus chemotherapy has similar outcomes with the Keytruda plus the chemotherapy. So what will be an interesting will be an head-on comparison between these two molecules, but still so far the standard of care has been the Keytruda plus chemo. And I don't think so there would ever be a trial design. But yes, this molecule also shows that with the addition of the chemotherapy in more than 1% PDL1 in with semilumab shows a durable response in 20% of these patients across histology, irrespective of in the 2 years, and improving the overall survival. The next molecule we'll be discussing will be the ivonescimab. Again, for the PD-L1 positive, it had an head-on comparison with Keytruda as the first-line treatment in the Harmony trial. Was presented as an abstract in World Lung Cancer Congress in 2024. Now, with this population, next study, it was a phase 2 study, and you could see there was nearly a doubling of the PFS from 5.8 to 11.14, and the hazard ratio 0.5, meaning 50% more people without any progression at 1 year benchmark, with nearly 9 months of follow-up. And if in terms of safety also, it did have a significant proteinuria and transaminitis as compared to the pembrolizumab. And it also had hypertension and laboratory abnormalities. So again, anything which is better than pembrolizumab is showing a promising, still a phase 2 study, but yes, a molecule to look forward to. The third molecule, which we'll be discussing today, will be an antibody drug conjugate. That's sexituzumab govitecan, tinomitican, and in combination with the KLA A16, which is an anti-PD-L1 as the first line treatment of the patients in advanced non-small cell lung cancers. It's a phase 2 OptiTrop Lung 01 study. Now, again, in the study, since it was a phase 2, so the comparator arm was to determine what is the right dose of these two molecules. Sextuzumab in terms of 5 milligram per kg every 3 weekly, as with KLA 167, 120, 1200 milligram every 3 weekly, or it is an 900 milligram every 2 weekly and 5 milligram every 2 weekly in terms of the response rates, the duration of response, and the progression-free survival. Now, with lowering of the dose and lowering of the intervals, the response rate increased. So 77.6% of the patients had better survival and lesser chances of progression, and more responses as compared to increasing the dose to every 3 weekly. Now, 40 and 60 population were randomized. And if you look at probably a very short month target of 6-month PFS, all of them had great responses in terms of more than 80%, 85% in either of them across the histologies. The more the PDL1 score, you could see 91% of them having 6-month progression-free rate, and those who have less than 1% also deriving a benefit of around 80% of them. So that means that this combination is going to be a potentially game changer with two different pathways combining together, an immunotherapy and an antibody combined together, making a difference in terms of response rates, disease control rate. What was astonishing was the second last line, which is the disease control rate. Irrespective of whether the TBS was done or not, I believe we had a response and the disease control was there. So again, this is something which is very, very important. Now, out of those 40 patients, one did have ILD, which was a grade 2 and no grade 3. Uh, Definitely anemia, thrombocytopenia, the leukopenia, and transaminitis are the side effects that are looked forward to. And that's where what would be next futuristic is to compare with the standard of care, that's Keytruda, and that's where the next phase 3 trial is going to be Profuse 007, where the Secukinumab plus pembrolizumab is going to compare with the pembrolizumab alone. So another interesting outcome to look forward to. Now, Depotumab has been making a lot of noise in the second line lung cancers, and that's where this trial was presented. The Tropion Lung 01 study, where Depotumab was compared with the docetaxel, which was the second line standard so far when the trial was designed. You could see overall survival did have an impact in terms of numerical hazard ratio of 0.94. So crossing unity not making much impact. And if you look at the, the overall survival in terms of those who have a non-squamous histology, hazard ratio was crossing unity 1.05. So again, no doubt 16% benefit was there, but which population it benefit, not much known. Now, the next thing that is coming up is the uh, in terms of the TROP2 markers, and that's where I believe the West has taken a new dimension of getting up a TROP2 marker being done. So what they do right now is to do a normalized membrane ratio using a quantitative continuous scoring. All those patients with TROP2 done by an immunohistochemistry assay, they were analyzed and the whole slide imaging was done. And all of them was put to an automatic imaging module, that's an AI-based module. And it was stratified in terms of whether it is a positive or a negative in terms of more than 75% of tumor cells with TROP2 NMR ratio of less than 0.56 or less than 75% of the tumor cells with the TROP2 NMR ratio of less than 0.56. So specifically how they measured was the optical density in each of these tumor cells, and they stratified based on the tumor cells and the non-tumor cells. And the ratio was calculated in terms of those who had a membranous optical density as compared to those who had a membranous plus cytoplasmic density. And that's where this method of quantifying the biomarker evaluable population was done in the Tropion uh, lung 1 study. Uh, So, and based on this, you could see those who were NMR positive, the PFS increased in terms of by the hazard ratio of 0.57, meaning a 43% uh, reduced chances of progression if you are NMR positive and you are given the Depo DXT. And those who have NMR negative population, the ratio cross the unity, showing that the drug doesn't work here. And that's where I believe Depo did make its impact as to calculate those patients with a NMR positive in the TROP2 uh, study, and that's going to be probably the futuristic model now. So I conclude my slides here and would love to answer any questions if there are any.
Hello, Dr.
Yes.
Vikas.
Yeah.
Yeah. Dr. Vikas, thank you for elucidating the role of immunotherapy in a nice way. So, what do you think is the future going ahead in this space with the coming in of ADCs now in lung cancer? We all know about the Harmony study and the PFS, doubling of PFS compared to Keytruda monotherapy. So, how do you see it from there?
So definitely it's going to make a huge impact in terms of not only increasing in the, if you look at the 6 month disease control rate between the addition of the antibody drug conjugates and the immunotherapy, we know that immunotherapy does work, and it works in a subset of population, but not in all population. And that's where we need to find out as where it doesn't work. And that's where the sexituzumab did have its impact in terms of uh, those who had a positive uh, in terms of sexituzumab given with the anti-PD-L1 inhibitor. Um, the disease control rate was 100% irrespective of whether the TPS was less than 1 to 50 or more than 50. And in terms of another population is that even if the disease progress after this, uh, docetaxel was what was considered as a standard, and that's where the depot also propped up in terms of the NMR ratio of the depot, and they have taken the depot probably to a next level. My Conti
I think we lost his voice in between. So,
one percent, 1 to 50%, and more than 50%. It has always been confusing. And what strain, what method to use, inter-observer variations, the taking it to an AI and quantifying and finding the right population where the depot works is probably is going to be also next game changer.
right. So, thank you once again for elucidating the role of immunotherapy and its way forward in metastatic NSCLC. So, after this talk, we go on to the next talk, which is on the management of localized non-small cell lung cancer. We all know that this space has seen a lot of changes in the last 1 to 2 years with a lot of data sets about neoadjuvant therapy coming into the foray. So, what exactly is the surgeon's perspective when we talk about the resectable or the borderline resectable early lung cancer is what we are going to discuss in this next talk, which is by Dr. L.M. Darlong, sir, who happens to be a well-known entity in thoracic oncosurgery, chief of thoracic oncosurgery in Rajiv Gandhi Cancer Institute. Sir has been at the pioneer of thoracic oncosurgery and has been a source of inspiration to many. I welcome sir on this Sunday morning, and sir, good morning. Please take it forward.
Rajat, good morning. Thanks a lot, Rajat, for having me here. It's definitely interesting times for, thoracic oncosurgeons in this era of immunotherapy. A lot of things have changed around in this era. So I will try to basically focus on what the surgeon has to see basically in terms of the role of immunotherapy in this cousin area, because we cannot ignore it. This is the fact now. Uh, I'm not able to move my slide, something wrong. Okay, so I'll just present with the old slide. This is what we have been seeing, for a long time, till recently. Stage 1, basically surgery or radiation. Stage 2 was surgery plus adjuvant chemotherapy, nothing else more than that, maybe radiation. Stage 3, some group went for surgery, but most of the time it was basically a CTRT and then lately the Pacific came, so it became immunotherapy also consolidation. So this is just a gist. You can see here, I mean, now a lot of change for stage 1A, and beyond that, basically from 1B to 3A to 3B and 2 disease. These have all now become to a group called resectable, and wherein you basically have a permutation combination of surgery alone for stage 1A, that's the tumor up to 2 centimeter or 3 centimeter, and then beyond that, uh, where you have a combination of chemo or chemo IOs in the pre-op in the neoadjuvant setting or in the peri-op setting. And obviously the unresectable group, they all basically go into the Pacific group. So it's a clear cut now, it's resectable plus unresectable. Again, in this way, I can show you again up to 3 centimeter, it's surgery. Above 3 centimeter, a lot of role of systemic agents, that's chemo and immuno in the perioperative setting, as well as the adjuvant setting or in the pure neoadjuvant setting. And obviously the unresectable, it goes for the Pacific way. So in one way, the IO has become a game changer, especially, I mean, for lung cancers in stage 3 section, and which has been percolated to the early stage group from 3 to 4 centimeter size onwards and N1 disease. So as a surgeon, we all know, I mean, immunotherapy is very good, but based on the concept how it works, it causes ITs. That's basically inflammation anywhere. It's immune mediated, and which the medical colleges also are very much aware in terms of the eye lung pneumonitis that they have. So this is one area, I mean, surgeons are scared of also, and obviously the medical colleges are also very much aware about it. Uh, so in this era of immunotherapy, it's very, very challenging now for the surgeons. We have to define resectability in the upfront setting, because this is how we are going to manage cases. Like, we don't start with some systemic agents and say, okay, we're going to decide next how we're going to operate about it, think about it. It is now basically upfront to decide if they'll make it. Basically, is the patient a resectable one or not, or unresectable? So a lot of responsibility now lies along with the surgeons. And if you see as such, for resectability from a surgeon's point of view, it is like a real estate. It's location, location, location. Everything depends on the location of the tumor. It is not the nodal factor. It's basically the T location of the tumor, which decide. So we have to make a lot of decision. The surgeon has to make his own decision based on contrast CT chest. He doesn't have to rely on the report of the CT chest. He should not ever rely on the report of the CT chest. He has to basically see the imaging himself, and if required, do a bronchoscopy to see for a lesion. And in some case, they have an MRI in case we have some confusion in terms of the mediastinal involvement. And this is what we have from the recent ISLC. You can see that, I mean, when you do an arterial section, the OS improves about 78%, and it comes to almost half when it's R1, and obviously very dismal 28% when it's R2 resection. So the aim is basically you should be able to achieve an R0 resection right from the beginning. So the surgeon's role is very, very important. And the focus of immunotherapy in this area, again, you all know, I mean, we are looking at DFS and EFS because OS takes more longer time, and so these are the shorter ones like DFS and EFS in terms of the breast cancer that we are seeing. And obviously the pathology gives us an immediate idea about in terms of MPR and pathological complete response. And this is something we surgeons are very scared about, fibrosis. Previously, our radiation oncology were giving us a lot of fibrosis, but now immunotherapy is equally capable of causing fibrosis, especially at sites where it has responded well. So this is an area, I mean, which causes a lot of difficulty to the surgeons. The work of the study definitely is going to, I mean, get more and more complicated, but still, I mean, we are if we are able to give a good OS, so that's very much worth it. And so for fibrosis, I would say it's mainly the hilar and the N1 nodes along the vessels, which are more difficult to operate. We are not really scared about the N2 nodes because they are easier to tackle. They are not along the major vessels or organs because they are quite in the mediastinum. So these are more easily tackled. And as a community, as a surgeon, we should understand that immunotherapy doesn't make an unresectable tumor resectable. It may reduce the size, it will reduce the size of the tumor, which is helpful during surgery, especially if you use a minimally invasive technique. So you don't have to manipulate the lung much. But in terms of making resectable to unresectable is something we still do not really believe in right now, though it might change in the future. So these are few of the trials that are basically in the phase 3 and still going on where OS is expected. You can see that all of them are basically measuring outcomes of EFS, DFS, EFS, and DFS. And as they mature later on, we'll get to know about the OS. Again, this is just to show the setting. Some of them are neoadjuvant, wherein it is given the pre-op setting, that's the checkmate 816, and then purely neoadjuvant followed by surgery, and then just observe it. Some of them are basically adjuvant, that's basically post-surgery. Immunotherapies are started, like IMpower1 as keynote studies. And the perioperative setting, that's basically when you start with chemo IO in the pre-op setting, and then do the surgery, and then continue on in the adjuvant setting in the post-surgical period. So these are some of the other phase 3 adjuvant studies in the resectal NSCLC setting, which will let us know basically what's going to happen when is the ideal time to go in with chemo IO in all such cases. So from a surgeon's point of resectability, I would let's see the two factors mainly that we need to know as surgeons, the tumor factor and nodal factor. So it's very difficult to clearly identify, describe
Hello, Geetika, can you check the connection? I think has been lost at Dr. Darlong's side.
Yes, sir. Dr. Dalung sir side network issues. I think he's left. I'm calling you.
Yeah, okay.
सर सर का नंबर ना स्विच ऑफ आ रहा है.
Okay.
So can we wait 1 or 2 minutes?
Yeah, I think we'll wait for 1 or 2 minutes, and if he's not reachable, then we may go on to the next talk.
Okay, sure, sir.
Yeah, I'm joining now. I'm joining. Something wrong with it. It's uh, can you see my screen now?
Yes, sir.
Yeah. There was some issue with the net. So this is a classical case wherein the bulla is in the upper lobe and the tumor is also in the upper lobe. So a surgery is basically equivalent to alveolus along with a curie dissection for the lung. Next, sometimes the CT scan shows that the tumor is involving the aorta, like in this case. So it's very important that the planes are not well defined, but it's not infiltrative. So these are cases wherein you can know basically it's not infiltrating. So a surgeon has to decide beforehand. It's basically not the case in such case. Again, these are cases wherein you see the tumor is in along the main pulmonary arteries. So you have to make a clear-cut decision right from the beginning that it's a resectable case, like you can see here on table here. I mean, this is not infiltrating. These are basically just averting. So all these are decisions surgeons have to take, and you should be able to perform a bronchial sleeve, a vascular sleeve, and obviously you should have good backup in the post-op period. So in the era of fibrosis of IO, you can see that N1 and hilum are very much involved. As you can see in this slide, it is mainly the nodes along the vessels. That's the pulmonary artery. That's the N1 which are causing difficulty in the surgery, and not the N2 ones. And as per ISCLC criteria, it's important we do a complete mediastinal node dissection. Like in this case, you can see the CT here. The surgeon sees it very well. The lobe nodes are very distinct and to these N2 sides, and they are very much resectable. Unlike in this case, if you see here, you can know it from upfront. It's not a resectable case. So this case go basically for a definitive CTRT or a Pacific way. And this just to show you video how the nodes become in the hilar area in post-IO. They're quite sticky, you can see here. I mean, everything is quite frozen, fibrous. They become more difficult to dissect. Uh, Same here. I mean, yeah, these are the nodes along the pulmonary artery. You can see this how the nodes get fused, fibrous. So you have to basically negotiate all these areas very, very slowly, smoothly, and not be in a hurry. So one of the concerns of the surgeon in this era is basically is there an opportunity for missed surgery? Some cases might not go on to have surgery. Yes, definitely some of the cases are there. So definitely we have to basically be choosy in selecting our case who are to go for preoperative chemo IO. And obviously the difficulty in doing surgery has increased with IO. It's in about 40 to 50% in the newest studies. And the drawbacks we cannot predict the pathology finding. I mean, how they're going to respond, and there tend to be more conversion to a minimally from the MIS or minimally invasive surgery technique. And this is just to show you the advances in the neoadjuvant systemic treatment for resected lung cancer. You can see there's a drastic jump from to mid 2010 to 2020. I mean, all the trials have come a long way from this year 2020 onwards. So to conclude, I would say that evidence for perioperative IO is getting stronger, and it's becoming more and more acceptable for our medical community to resect, to see lung cancer as being resectable or unresectable in the N2 setting. And the surgeon's role is very, very much vital because we need to say upfront whether these are resectable or unresectable. And for the surgeons, you can take your time for difficult cases, get R0 resection done, but safely, and don't hesitate to do an open surgery, and definitely call for help. Thank you very much. This is what I think is the surgeon's perspective in the current era of IO.
Thank you, sir, for a very nice presentation on the role of surgery, the medical oncology perspective also you tried to bring in. So what is your take on some oncologists who would try to understand that probably if the patient has got N3 disease, then probably giving a neoadjuvant immunotherapy would make it resectable. So something of that sort also keeps on going on in the mind and in the discussions in the tumor board, just to get the give the best benefit of PCR or MPR to the patient. So what is your take on it as a surgeon?
I mean, as I've said in the beginning, I mean, IO, we don't expect an unresectable to be converted to resectable at the present era. If you have proven entry disease, I would think we should basically go in the Pacific way at the present moment. We still don't have data for entry disease.
Yeah. And N2, you would like to assess in the very beginning in the MDT approach whether this can become resectable or not.
Yes, so in the MDT, we decide upfront. I mean, we have confirmed pathologically with EBUS, whatever tools you have that it's N2 disease, and then you decide about resectability upfront. It is not wise to say, okay, well, okay, we'll start with some systemic treatment, we'll assess again. No, I mean, that should not be the way, because you have to give all the benefits in the upfront setting. I mean, chemo IO, or if it's mutation positive, in that case, obviously we don't go for IO, but still, uh, in the beginning, I mean, the surgeon, the oncologist, the radiation people have to decide, okay, this patient is operable, it's resectable, so this is the pathway we use.
Okay. And so the last thing is that the various trials are there, some in the only in the preoperative, some in the perioperative, where the inclusion criteria is a bit different. Some have taken up to T2 N2 and some have taken up to T4 N2 as well. So as a surgeon, what is your take on say a T4 N2?
T4 and 2 as a surgeon, see if the lesion is involving the diaphragm. A diaphragm from
Yeah.
an resectability point of view, it is very, very much resectable.
Okay.
Okay. But if it is involving mediastinum, so that's
Yeah.
I mean that's a gray zone. I mean I would not really want to go and involve in the mediastinum. But if
Okay.
you again like say it's a pericardium,
Mhm.
it's very not very very common for tumors to go and involve the pericardium because the heart is such a structure, it just pushes off, just like the aorta. Aorta is also quite firm. I mean, any tumor going infiltrating the aorta or the pericardium is not very very common. They tend to
Okay.
basically go and adhere to the more silent, what do you call, the static ones. Yeah,
Okay.
definitely diaphragm involvement is very very much amenable to resection, not towards the mediastinum.
Okay. So I think you have already begun to discuss all the early lung cancers in the tumor board for a medical oncology opinion as well.
Yes, definitely. We always take our opinion from medical oncologists, especially for N2 settings. N1
Yeah.
setting, we are still I mean, trying to figure out basically because of the economy involved and all those things. But N2 setting, we definitely try and push them and get all markers done in the pre-op setting. I mean, for
Yeah.
EGFR and ALK at least.
Yeah. Okay. Right. So thank you so much for this
Thank you, Rajat.
information
Nice
and
seeing
talk.
you
Thank
again.
you. Thank you. So, with this, we move on to the next talk, which is by Dr. Deepak Kopakka, and he is going to speak about the role of the targeted therapy in the driver mutation positive metastatic NSCLC space. Dr. Deepak is there.
Yes, sir. Deepak Kupakar sir is there.
Yeah, sorry.
Okay. Dr.
Hi,
Deepak,
thanks,
good
Rajat.
morning.
Thanks for the opportunity. And I would be actually, I was a little worried when I got this topic on role of targeted therapy in NSCLC. But I think later I restricted only to the newer advancements that have been happening in the space. Yeah. So, uh, yeah, are my slides visible?
Yes.
Yes, sir.
So, so targeted therapy in the NSCLC space are evolving. When I say evolving, yeah, this is where it stands. A couple of days back, we've got one US FDA accelerated approval just a couple of days back, and that is the trajectory with which approvals are happening in the space and the way these treatments are evolving. So this is a table showing on the recent advances. As recent as of February 4th, we had got one approval that was for uh, NRG1 fusion abnormalities. This usually pairs with HER2 and HER3 moiety, and we've got a monoclonal antibody called zenocutuzumab, which is approved, which has got an accelerated US FDA approval for pancreatic and NSCLC patients expressing NRG1 fusions. So in this context, we've got a few approvals of older drugs in different settings. One is the approval of osimertinib in patients who've received chemoradiation as maintenance for indefinite period. We've had data from immunotherapy in this space, and the space really didn't move much since after the approval that we got in the later 2018 period. But this is a newer development that we saw in the space. Osimertinib showed a significant improvement in PFS with an hazard ratio of 0.16. So this is again what we see with the ADAURA data, hazard ratios of this magnitude. The median PFS was more than 3.5 months compared to 5.6 months. Little surprising in the study was the use of indefinite osimertinib, unlike what we saw with the ADAURA data. The reason was that most of these patients progress if they are not on consolidation therapy. As we can see here in the control arm, which in the standard of care arm, which did not receive any treatment, the median PFS is very low, which is 5.6 months. The OS data is still immature, and considering what happened in ADAURA, I'm expecting there will be a significant trend towards OS benefit, but we need to wait for the data. Next, switching gears is about the ROS1 space. The ROS1 space is evolving with macrocyclic drugs taking up the prime role here. We've got entrectinib approved in this space. Now we have two interesting drugs. One is repotrectinib, This data got published in NEJM last year in 2024, which is a phase 1/2 study called the Trident 1 study, in which patients who had upfront repotrectinib and also patients who had repotrectinib in second line post exposure to chemotherapy was evaluated. The peculiarity of drugs like repotrectinib, taletrectinib, which is another very promising ROS1 inhibitor that's coming up in this space. The studies with taletrectinib are called the TRUST studies. And we have the entrectinib. These drugs have very good activity in the brain. These are active against the resistant mutations that happen in ROS1 called the G2032R mutation. So the reason why these are active in these group of patients which have a brain metastasis, or patients who have this resistant mutations near the gatekeeper called G2032, is because of this structure. These are microcyclic drugs like lorlatinib. These are macrocyclic structures which have very tight binding to the TKI domain and have a very good penetration because of the structural efficacy these drugs bring on into the brain also. So going into the details of the study, patients who harbor ROS1 gene fusions were randomized to receive, not randomized, sorry, were receiving 160 mg of the drug followed by 160 mg BD dosing. The study evaluated patients who are TKI naive, and the primary endpoint was the overall response rates. Significant overall response rates were seen even in the brain. We can see here in the water plot curves, very good response rates, and tumor burden has significantly come down. Patients who received both chemotherapy and patients who have not received any prior chemotherapy. So even in patients who got brain metastasis, we've got responses which are almost 70% at the end of 2 years. And patients without brain metastasis, we can see there's a flattening of curve, and patients usually tend not to progress while they're on these treatments. So similarly, what we see with lorlatinib in the first line setting in patients who are ALK positive. A very interesting thing, and I think which is what we do in most of our patients who progress on EGFR inhibitors or ALK inhibitors who have oligo progression, we try to we try to do radiation, we try to do surgeries if the patient have oligo progression. And here the study try to see in patients who do not say who were treated with local treatments like surgery, radiation, the time of progression. There was a significant benefit, and one of these patients who underwent surgery at the time of oligoprogression, the response continued. It's a very interesting thing about the study that a significant, nearly half of these patients tend to derive benefit at 3 months if the oligoprogression is being addressed. Coming to overall response rates, a significant improvement in overall response, significant overall response rate benefits were seen in patients who received chemotherapy or who not received chemotherapy but were TKI naive to the tune of 70 to 80%. This is what we see in patients who are again who respond very well to TKIs like mutations like ALK, EGFR, and RET. CR rates were around 13% and a partial response rate to the tune of 66% were seen. The clinical benefit rate is around 94%. Median PFS is around 35 months. So nearly 3 years the patients continue to respond to these drugs. So very interesting and very promising to see these kinds of benefits. We've had crizotinib, which again has a good duration of response somewhere near 20 months. We have lorlatinib again to the tune of 24 months. These are the benefit PFS that we see with these drugs. Drugs like taletrectinib and repotrectinib are having a significantly longer PFS advantage. Most of the safety, these drugs are well tolerated. The peculiarity is, like I told, these are drugs that go into the brain. So we have a lot of neurological toxicities like dizziness. That is a characteristic, probably because of the structure of the drug, we have these kinds of side effects in these patients. Next, switching gears, we have adagrasib, which is a KRAS G12C inhibitor. This is evaluated in the second line in comparison to docetaxel. There were 2 studies which were late-breaking abstracts in ASCO 2024 and ESMO. This is with regard to the PFS benefit, and compared to docetaxel, there was a significant PFS benefit. Almost a 15% improvement was seen, and a hazard ratio of nearly almost 40% risk reduction for progression was seen. In the study, there was a significant overall response rate benefit that we can see with this study with this drug compared to docetaxel. Intracranial efficacy also, there was a significant benefit both in terms of the response rates and also almost a 30% improved response rates was seen. This was later an exploratory study was done that was presented in ESMO, which evaluated this specific population of patients who had neurologically stable brain metastasis. So here we can see again in terms of intracranial time to progression, who are in patients who had baseline brain metastasis. Though the study population, the number of events that have happened were around 20 to 25%. In median intracranial time to progression was 18.6 with adagrasib, whereas docetaxel was not reached because of the small sample size that was there with this. Compared to patients with brain metastasis and those without brain metastasis, actually the patients without brain metastasis, there was a significant improvement in terms of PFS that was seen with almost nearly a 50% reduction for progression in the brain. Whereas in patients with brain metastasis, though adagrasib fares a little better, I think the sample size cannot really determine whether this is statistically significant or not. But I think at least in patients who do not have brain metastasis, it is worthwhile considering these drugs in the second line. Again, coming to the drug, which is amivantamab, which was a lot of data that has happened in this space with the bispecific monoclonal antibody targeting EGFR and MET. We had data coming up both in the upfront and also post-osimertinib space in this setting. We have had a recent press release by the company by JJ saying that amivantamab or lazertinib combination did show an overall survival benefit, which is probably we actually still have to wait for the FLORA2 data to see if that both with whether combination therapy in upfront EGFR positive lung cancer would be there to stay. So the drug is the combination is a little difficult to handle in practice, but again, coming back to the data that was discussed, here the study arm included EGFR, common EGFR mutations like exon 19 deletions and exon 21 L858R, and were randomized to receive lazertinib plus amivantamab, osimertinib versus lazertinib monotherapy. And here there was a statistically significant advantage of lazertinib amivantamab compared to osimertinib with a median PFS of 23.7 months versus 16.6 months. So this is the second best phase 3 data that showed a combination therapy. Flora had a slightly, though it's a cross-trial comparison, a slightly higher PFS advantage compared to this combination. The study did show benefit in patients who had high-risk population like brain metastasis, TP53 positive disease to begin with. Again, there was this combination that again received an FDA approval, that is patients who received pemetrexed, carboplatin and amivantamab compared to the standard of care. Significant benefit was there even in patients who got brain metastasis. A median PFS advantage was around 6.3 months versus 4.2 months with patients who received just pemetrexed, carboplatin. The combination there was also there were higher venous thromboembolic events that was peculiar with this study molecule. We are with the availability of subcutaneous, probably the subcutaneous formulation of amivantamab, probably the allergic reactions, we would not see the anaphylactic reaction that we see with the IV infusion form, but there are thromboembolic events that are little characteristic side effects that I see with amivantamab in this study population. Now coming to small cell lung cancer, there a very practice-changing update that we got, similar to what we see with the Pacific data. We had the Adriatic study, which used durvalumab in for 2 years post chemo radiation. A significant benefit was seen both in terms of overall survival.
Sir, sorry for interrupt you. Kindly conclude your talk in 1 minute.
Yeah. So significant overall survival and PFS benefit was seen with almost hazard ratios of 0.73. It is a well-tolerated regimen. I think that combination is here to stay, at least in localized small cell carcinoma lung patients. This is a very interesting combination, which is ifinatamab deruxtecan, which targets B7H3, which is significantly overexpressed in patients who've got small cell lung cancer. This is the ideate lung 1 study, which compared 8 milligram per kg versus 12 milligram per kg. The 12 milligram per kg had significant overall response rates and significant disease control was also seen with this, but a little more GI toxicity was seen and anemia was seen with the 12 mg per kg, following which the ideate lung 02 study, which is a phase 3 study, is combining this drug IDXD versus the standard of care in the second line. And probably it is some promising drug, which would be a tough combination to lurbinectine. And the bite that is being used, tarlatamab, that's being used in small cell lung cancer. We've got tumor treatment field. We got the phase 3 data of tumor treatment field, which used the standard single agent IO or docetaxel in the second line, which was used, and the patients received TTF in one arm and TTF was not used in another arm. Use of TTF showed a 3-month overall survival benefit. Again, it's a very difficult treatment. I've not actually used this, but almost 18 hours every day, the patients are supposed to use the treatment. The TTF device has to be mounted on the chest. In this, a little cumbersome, a little higher skin toxicity was there in this population. So we are waiting for the phase 3 lunar data, which is bringing this tumor treatment fields in the upfront setting. Thank you for the organizers for giving this opportunity.
Thank you, Dr. Deepak. Very nice presentation on what is new in this particular space. I think we'll be talking about this more in the panel discussion that follows. Thank you once again. So I think we move ahead now and talk about the actionable driver mutations and the role of CTC in the management of metastatic NSCLC. We are going to have a panel discussion now on this particular topic. And the moderator for this topic is Dr. Ulas Batra, sir. Sir, of course, needs no introduction. We all know him. He is the chief of medical oncology the thoracic field and co-director at Rajiv Gandhi Cancer Hospital. Sir, good morning and welcome.
Thank you, Rajat. And seeing both of us in jackets and Dr. Deepak in a stethoscope makes me believe कि यार patient भी देखने चाहिए Sunday को. So nice, Dr. Deepak. I think you are doing it from the hospital, or maybe you have taken rounds. So good, people should work on Sundays. I totally believe in L&T philosophy of 90 hours per week. Rajat, how many hours per week now? 120?
Yours is more than 90, sir.
I am asking you, how many is yours? 120?
Mine is only 10.
Ah, come on. 10 hours of sleep per week, I guess. Dr. Deepak, you were saying something.
Oh, no, thank you for that.
No, it's nice. It's nice to see people working. My only thing is, if I only could have worked today along with Rajat, that would have been even better. On that note, can I invite my panelist? I hope this is not being recorded and shown to my wife. She will definitely murder me if she hears of 90 hours a week. Okay. So my panelists are Dr. Sunil Pasricha, one of the best pathologists that I have actually worked with, and source of support. Whenever in doubt, just call up Sunil from RGCI and he will have an answer. And most of the times he will actually call you up and say, "Boss, इसमें ना ये कुछ अलग सा लग रहा है, ये करा लेना." So thank you, Dr. Sunil, for always being there with us.
Thank you.
And Dr. Animesh is a good to see that you're also working from home. I hope you're not seeing slides right now. Dr. Animesh, who's a medical oncologist, Kripa Shankar, Vikas Salreja. Vikas Salreja, I'm 100% sure is going to be working right now. Vikas, are you here? Vikas नहीं होगा. Vikas chemo दे रहा.
No, sir. He's
I
in
know.
he's
I
in
know.
driving.
Yeah, no, he's not driving. He's giving immunotherapies. Or forget immuno. He'll be giving triple immunotherapies.
No, he's doing that in the car.
He's doing that in the
giving
car. Fantastic. And Ankur Varshney.
Hi, sir. Good morning.
Hi, Ankur. How are you? And Dr. Pratik Chandani. That is what I was thinking. In a molecular oncology panel, if we don't have a molecular oncologist, it will be difficult. Dr. Pratik, are you here?
Yes, I'm here.
Oh,
Good morning.
Fantastic. And thank you, Dr. Pratik, for all the help that you gave us for the biomarker research project also. Appreciate that.
Anytime.
And since Vikas is not there, can I invite Dr. Rajat Bajaj also? So, I was thinking of asking easy questions to everyone, difficult questions to everyone else, and easy to Vikas. So I'll ask easy questions to Rajat now, and we will go in for difficult questions for everybody later. Okay. So CTC, cfDNA, biomarkers, and liquid biopsy. And whenever anybody talks about liquid biopsy, mine and most often the patient's first reactions are like this, आप कहाँ थे? आप पहले क्यों नहीं आए हमारे पास में? Just do something from the blood and then finish it off. My subsequent reactions when I look at the liquid biopsy and look at the final reports is, अरे जरा रुको जरा सबर करो, the picture अभी बाकी है, and let's put the liquid biopsy to test. Liquid biopsy is a very nice thing, but I think let's not get carried away. As a clinician practicing oncologist, I think we need to hold our horses and we will see what exactly. There are strengths of liquid biopsy, there are demerits of liquid biopsy, and we will discuss it during this panel discussion today. Now, let me just start with everybody. So, let me start with Sunil first. Sunil, as a hardcore pathologist, are you a believer of liquid biopsy? And I'm specifically talking about lung cancer right now.
Yes, definitely.
You are a believer of liquid biopsy. Then why are you still in histopathology, Sunil? I mean, I have told you many times to move over to molecular pathology. Why are you still in histopathology?
No, I'll see that molecular part as well.
Okay, you see the molecular part as
Yes,
well.
yes, yes.
Fantastic. Rajat, believer, non-believer?
So very much a believer.
Very much a believer. Vikas has come. Vikas has given 5 immunotherapies today, but that doesn't mean that I'm going to let Rajat go from here. Animesh, believer, non-believer?
Believer, sir.
Believer. Fantastic. Vikas, believer, non-believer?
Strong believer.
Oh, strong believer. Fantastic. Dr. Pratik, I think we can just stop the discussion right now, and since everybody is a believer,
End of discussion. Get back to the
I know,
clinics.
get back to the get back to clinic
Writing more immunotherapies.
and give more immunotherapies. Okay, Dr. Pratik, believer, non-believer?
Believer.
Believer. Fantastic. Ankur?
Believer, sir.
Believer. Fantastic. So, next question for everybody over here is, do you think liquid biopsy, Sunil, I'll come again to you. Do you think it's a main actor in a cancer patient's journey or a supporting actor?
As of now, it's it has a supporting role, which
It
is
has a
well
supporting.
established as a supporting role as of now.
Okay. Animesh?
Same, sir. No different.
Supporting role. Fantastic. Dr. Pratik?
Yeah, it has a supporting role.
It is a supporting role. Rajat?
So I think not one answer here. It depends on
Rajat will say it is the main actress over here, actually, behind which everybody is running. Forget the actors. Okay.
No, so I mean, it depends on what is the time that we are doing it. If it is an upfront metastatic that we are talking about, so a droplet digital PCR for an EGFR would certainly be there. But if we are talking about the others, then we generally have tissue in lung cancer. It is not that we don't have tissue in lung cancer. It's not like others where we won't have tissue. But if you're talking about multiple progressions or even if a second progression, maybe we don't have a tissue, patient is not having that much of general condition for a repeat biopsy or something, then a liquid biopsy certainly is the way to go ahead.
Okay, so Rajat, I just wanted to remind you, that the elections in Delhi are over now. You don't have to be a politically, diplomatically correct answer doesn't have to be given. So, between a main actor or somebody like a supporting actor who's going to kill, okay, this is what I'm going to ask Sunil. Sunil, do you think liquid biopsy is going to be like a Katappa who is going to kill the main actor in the Bahubali Part 1?
No, it's not going to replace it, but definitely it will provide and in fact, as of now, it has providing a good supporting role, but it's not going to replace it.
It's not going to replace it. So, I mean, I think everybody really believes that a liquid and tissue biopsy, a combination of that is the way to go. Dr. Pratik, do you agree with which one of the ones that you believe in?
So I agree with this. I would just add one more point, which is only in the limited settings when tissue biopsy is not possible. Liquid biopsy definitely has a potential to take a lead role.
Okay.
And it is taking as well.
Because the winning combo or Katappa or the main actor?
Liquid biopsy is like Rajkumar Rao in Bareli Ki Barfi.
Liquid biopsy is like Rajkumar Rao in Bareli Ki Barfi, which will finally end up getting the one. Did he finally get the girl?
So watch Bareli Ki Barfi and
I
then
have
we
watched Bareli
decide.
Ki Barfi. I'm not able to recollect it. So who finally gets the girl?
So it is a winning combination,
It's a
definitely
winning
at the end of the day. And
Okay.
it is one of those who underperforms in the first half, but then in the later half it overperforms.
Okay.
So I believe it gives you surprises. It gives you definitely important knowledge. And at the end of the day, it's not just the supporting; it's a co-actor, I would say.
It's a co-actor. Co-director is what my word actually, my designation also states that. I would totally agree with you on that, Vikas. Okay. So just to get some things running, this is a slide which I got from somewhere, which is very nice, you know. Liquid biopsy is like fishing. And by fishing, I don't think what you think right now, Rajat, is fishing. I know there will be a smile on your face because both of us know what you are thinking right now. So catching a fish means there's a fish in the sea. But if you are not catching a fish, that does not mean there is no fish in the sea. I mean, one of the most nicest words that I actually got. So if you get something, definitely there. If you're not able to catch a fish or if you're not able to get a mutation or a fusion, that does not mean it is not there. Number one. Tumor burden, you are more likely to catch a fish when there are lots of fishes. Fantastic. That means in late stages of disease, you are more likely to get the mutation active over there. In the early stages, in the screening one, which everybody said initially also, might be difficult to get the fish. So if the number of, if the ctDNA is lesser, if the mutation is lesser, you may not even detect it. What Rajat said also, PCR versus single gene versus NGS multi-gene testing. So you want to get by a fish net, that is a NGS. You want to get by fishing rod, that is an RT-PCR or a ddPCR. So I mean, these are the three very nice words which I actually got from some. These are not mine. I've just copied it from somewhere, but very nicely I thought, which summarizes the liquid biopsy actually. So these are basic rules. So now let me start with Dr. This was the fun part of it. Now let's come to the real good part of it. So let me start with the medical oncologist first. Dr. Ankur, or Ankur or Animesh can take it. Animesh has his video open on right now. So what does liquid biopsy actually analyze? I mean, there are a lot of things that you can do. You can do CTCs, you can do cfDNAs, you can do tumor educated platelets, you can do a lot of things over there. So, what does it actually analyze, or it doesn't really make a shit difference to us as long as you give us a report?
So from what I understand, it takes the CFDNA, essentially takes the CFDNAs and analyzes whatever abnormalities it can find. So RFLPs, VNTRs, any aneuploidies, and whatever. And based off that, it will get
So
an
so this is what actually it can analyze CTCs, EVs, cfDNA, proteins, the TAAs, microRNA, metabolites, methylation, ctDNA, a lot of things it can.
so
So to a medical oncologist, when you get a report, do you look at what is so is it a mutation from a cfDNA or from a microRNA or from a something? Do you see that in the report, or you say like a typical Punjabi one, Sanu ki, as long as you give me a EGFR mutation, I'm absolutely okay with that.
So to the best of my ability, I do try to assess what has been given to me and where it was, what abnormality was found and where it was found. Often I do hit a roadblock as to how to my understanding limitations, and then I talk to the pathologist or the molecular pathologist. I do not have ready access to a molecular tumor board, so I do talk to the molecular pathologist of the lab from which I have that report to be able to understand where that mutation has been found and what clinical significance I should attach to it. Also, of course, it becomes a question of like the VAFs cannot be read as the same in liquid biopsies as we can from tumor-based biopsies. So all of those variations can happen.
Dr. Ankur, do you really
Yes,
look
sir.
at CTCs or CFDNAs, or you say, no, it's okay, let me just look at the final VAF and EGFR and stuff like that, or you actually go down to where exactly it is being looked at?
No, sir, we look exactly what's the thing going on, and as possible, we also discuss with the molecular biologist so that how much clinical significance is there of this relevant mutation. But majority of time, this is usually a variant of unknown significance.
Okay, VUS is something. Rajat,
Hmm.
the most upcoming, not upcoming, already come and been there now. One of the most proficient users of liquid biopsy in Delhi NCR region.
So, sir, I think this has been there, and we have we are using it more and more now. A lot of calls now go to the molecular oncologist. Almost every report, like you said, that Rucozara is what we really tell our patients, that you should come after one day. We are busy today. Let us see and
Tumor board.
talk to the people at the back end who are equally important, and then tell you that.
More important.
I don't really see the CTC or the CFDNA. If at all that has to be seen, I would be all ears. But then generally discuss that with the molecular pathologist. What is it, pathogenic? Is it VUS? What is the VAF? And how much a clinical implication it is going to make?
Okay, fantastic. So let me go to Dr. Sham Agarwal sir has put some very relevant comments over here about CTCs. Let me go to Dr. Pratik. Dr. Pratik, CTCs have always, to me, CTCs have always been a bridesmaid and not really been the actual bride over here. So, what exactly is the problem at a molecular level with CTCs? Why have CTCs? They came initially in breast cancer, colon cancer, lung cancer. It has not really been, it's been always been the bridesmaid, never the bride. So, why do you think it has happened?
So that is because of underlying biological complexity. If you see, cell-free DNA is not getting released in roughly about 30 to 40% of the cancer patients. Now, ctDNA, CTC are even lesser in the quantity. They are released only in about 30 to 40% of the patients, and that too in the aggressive cases. So, relying on to CTC is very difficult. And the second challenge that we usually face is that there is not absolute biomarker of CTC. There are some generally suggestive and good accuracy biomarker, but we still don't have a single molecule which we can point out that this is CTC or not. Hence, there is a technical limitation. I'm sure with more
Yes.
science progressing, we'll be having more solutions, but it is just too early for CTC.
Okay. So I think, CTCs were initially directed in the year 1869. There are a lot of concern regarding the dissemination law of CTCs, whether it is by apoptosis, necrosis, or whatever. How do you detect it? How do you enrich it? There are a lot of concern with CTCs, and I absolutely agree with all the comments. When you look at the liquid biopsy today, you are actually looking at cfDNA. Very, very few labs. I think only Forbes Care in Pune does it on the CTCs. Rest everything that is being analyzed for clinical usage right now is basically on cfDNA. Is that a fair statement to make, Dr. Pratik?
Agree.
Okay, fantastic. So by and large, everything else is in research phase. What we do analyze on the liquid biopsy report for commercial usage is basically for cfDNA. So is ctDNA the ideal circulating biomarker? I think it is not an ideal, but by and large, it is all that we have. And right now, it is the best marker that we have right now. So now let me go to this now. Kripa, you have joined a bit late. So this is, basically the clinician's problem. I went to a conference yesterday and there were like 10 different molecular labs which were there. And everybody says, I am the best, I am the best, I am the best. Hum ye karte hain, hum wo karte hain. How do you decide about, how do you trust what all should a this is the poor oncologist, this is not a real oncologist, poor oncologist like us. What exactly do you want to look in a report, Kripa, when you look at a liquid biopsy report?
Perfect. First of all, thank you so much, Ullah sir. And I don't agree with that poor oncologist because I don't think you should club yourself along with us as poor oncologists.
Okay, I will say very poor oncologist now then for me. Okay, go ahead, Kripa.
No, but I think, like you rightly said, the platform on which it's done, the depth of sequencing, the number of reads, and whether it's done on liquid or tissue, and also looking at the WAP, the MAP, the mutant allele frequency as well. All of these parameters, the limit of detection of PSAs, all of these parameters are important for us to look at where it's been standardized, and also the tumor DNA content, the fraction as well. And that will all of that will have an impact on the yield, and as far as the reporting standards as well. Whether it's they whether they follow the ACMP guidelines as far as the tier 1, tier 2, tier 3, tier 4 classification of reporting is followed as well. So these in a nutshell, I think these are the parameters that I would look at, and whether it's from a standardized lab. And yeah, if I'm happy with all
So
of this, then I think it's viable for me to get it done. And cost as well,
let me
more importantly. Yeah.
cautious. Let me go to Dr. Pratik. Dr. Pratik, there was a comment about the VAF in liquid biopsy, and then there was a counter comment in by Dr. Sham, I think in the chat box, that VAF, when it comes to liquid biopsy, it is not important. I agree with Dr. Sham Agarwal. Sometimes initially when we used to see the report, I said EGFR in liquid biopsy is only 0.8%, not in a VAF. So I don't think that's the right statement. So what should a oncologist, when we look at it in a liquid biopsy report, so that we know what is happening is right.
Right, right. So this, I also broadly agree with the comment that WAP is not very important as we see in the tissue. But I would also emphasize that one should look at WAP even in the case of liquid biopsy, and that may help us understand first tumor load. If there is excessive tumor load, there will be very high WAP of cancer driver mutation. And second, in case of a germline alteration, the WAP will be off the chart. Okay, about 50%, 70%, or 100%. So you can easily distinguish whether it is a germline alteration in case of any familial, possibility.
And what about the depth? Do you really think a 1500 or a 750x is good, or you need to have a 30,000x or
No,
something which is there in
no.
a liquid
If I
biopsy?
disagree, in liquid biopsy, 750x is nothing. We
Correct.
definitely need higher coverage. At the bare minimum, I would recommend to go with 3000x to 5000x, and preferably near about 10,000x.
Correct. So, again, very, very important is at least a 5000x or a 10,000x is supposed to be there. VAF is not important, but if you have a higher VAF, look at the amount of look at the if a higher
Tumor
VAF.
load.
Think about the tumor load. Think also about the germline mutation.
Yes.
Also, one more important thing is that if you fusions are something which you are more likely to miss in a liquid biopsy report. By and large, it's a mutation. You are more likely to get more in a liquid biopsy report. If it's a fusion, you are going to be missing it more. Is that a fair statement,
Correct.
Dr. P?
Totally agree. Yes.
Absolutely. Sunil, Dr. Sunil, do you have any more comments to make in this as a histopathologist, or anything else in this? Okay, you by and large agree. So let's look at the clinical utility of liquid biopsy in lung cancer. To me, there are 4 ways in which you can use liquid biopsy in lung cancer: at diagnosis, which is the most important use; as monitoring to predict response, to determine the early disease progression and resistance pathway; and something which is going to come up, which is really a research pathway, is to determine the MRD in early and advanced stage. That is something which we are going to say. So one thing which I will come and say, is it concordant with a diagnosis with a tissue biopsy? Second is timing of tissue and liquid biopsy. So let me ask this question to all the clinicians. I'll start with Vikas. Vikas, both these questions. Do you agree that liquid biopsy is concordant with tissue biopsy? And if you have to send, when will you send? You will do a tissue biopsy, nothing comes in this, then you will send a liquid biopsy, or you will send a liquid biopsy first, then a tissue biopsy, or you'll send both together?
So I will take both the answers together. The question you asked about what does the oncologist look into the report. The answer to that is simply 4 things I do. I take 24 hours. So I ask whoever the lab who is reporting the report before sending the patient, send to me 24 hours before on a WhatsApp. Call the molecular pathologist who has reported, discuss that report in detail, read all the pages in detail. So whatever the jargon has been written in those pages, read in detail. Be it at bedtime, at whatever time.
You will
Third
get a
thing
good
is
sleep,
to
no?
upload that.
Once you read it in the night, you'll have a good sleep, I guess, or maybe no sleep if you do some stupid thing in that.
And third thing is to upload that on probably many of the AI platforms and softwares that are there. They all give you a good information, and then
Okay.
assimilate with the clinical profile of the patient. Also take from the molecular pathologist the raw data. So it not will not be useful right now, but in future, take that molecular raw data as whatever has come up. Because many of the mutations which we don't tend to overlook, many of the bands that are reported right now are missed, are useful in future because the science is changing.
Correct.
So I have seen, and that
Because
was there, but it hasn't been reported, and it came up later. So take that molecular data with you, because at the end of the day, it's a patient's personal private property, I would say, at the end of the day. And for me, liquid biopsy is a must in concordance with tissue biopsy for all patients.
So you want to send it concordant, concordant. Dr. Kripa, if you have a chance to send, let's say money is not an issue. Let's be there on the science. And let's say money is not an issue. You will
So
like to
if definitely if cost is not a constraint, I would
All.
you will like to send both.
Yeah, definitely. I think if the cost is not a constraint, I would definitely go with sending both together. And
Okay.
also, the current thing, I mean, like if you look for a tumor not normal match control as well, the MSK axis, for example, where they look at the normal match control as well. So, ideal world scenario, I think I would look at doing complementary testing with both the tissue and the liquid biopsy. And to borrow from you, I think I would say if you pick it up on the liquid biopsy, then it's as good as, you can go ahead and act on it.
And go ahead
If
and
it's
treat.
not there, then if it's not there, then yeah, you would have to look at getting.
Animesh? Fantastic. Animesh?
Same. If cost is not a constraint, I would prefer to send both.
So by and large, what we are all saying, and I'll come to you, Dr. Ankur, later, is that by and large, what we are saying is that we are sold on the science. What we are not sold out is basically on the cost part of it. If the cost of that actually comes earlier, then probably we will be sending both of them together. Is that the right thing, Dr. Ankur?
Yes, sir.
Okay, fantastic. So this was the Sanjay Popat study paper which got which he presented at ESMO, and what they basically found out that liquid biopsy actually picks up more tier 1 variants. This is there, but please again remember that the tier 1 variants also includes a P53 and KRAS, for which the treatments are not available right now. So can I ask your personal experience, Rajat? I'll ask you how many times in your busy practice of 120 patients per day and to Vikas 250 patients per day, have you sent something which is negative on tissue biopsy and positive on liquid biopsy? I know we don't have a structured data, but just a guess. Rajat?
So, sir, you said negative on a tissue, but positive on a
So this
sorry.
is exactly what happens when the meeting started. Rajat was in a red colored hoodie and now he has changed over. He's probably going to give more immunotherapies there. So this is the difference between a tissue and a liquid biopsy. Yes. Missed on
So,
tissue, positive on liquid.
so yes, I have had. There was a patient. I remember.
Approximately how much? Approximately how much?
So I would say about 5 to 7%.
5 to 7%. And Vikas? I think Vikas is not there. Okay,
Sorry, I
fine.
was on. I was on mute. I was on mute. 10 to 20%.
10 to 20%. So that is a huge number, I guess. And I think I agree with them to our rates is only approximately around 10 to 12%. We'll pick more mutations. We have picked more mutations of MET. We have picked more mutations of HER2 on a liquid biopsy. We have picked up lesser fusions on a liquid biopsy and more mutations on that. So that is there. I think timing of the test, everybody by and large agrees that we should do a complementary approach. If money is not an issue, we need to go ahead with a complementary approach. That is very, very important. And this is exactly, that is why I was hoping Rajat will keep on wearing the red one. And I can tell that this is Rajat exactly who is roping in money over here, but just change the shirt. Even the guidelines basically say that you should send it both together. And I mean, that is what I said, hum saath hain. We should send tissue and liquid both together. Now, let us say to Dr. Animesh and then to Kripa, let's say you have a report which is positive, a MET exon 14 splicing mutation, positive on liquid, negative on tissue. What will you tell the patient and will you treat this patient?
So, sir, I will say to in general, first liquid, with all caveats of the report having been discussed with the molecular pathologist, and I assume that at least the science behind that report is solid, and I believe that that report, I mean that mutation that has been detected is a valid one. The tumor fraction in the liquid biopsy is say like 2% or at least more than 1%. So all of those caveats aside, I will recommend recommend to the patient that I believe this to be a clinically relevant one, and there is definitely an around 10% chance, because that is what I also have seen in my practice, that there is around a 10% chance of something having been missed on the tumor tissue.
Correct. So I think, and there are many studies, this was the FASTEC study, which was there in the for the EGFR and Vision study, which actually used liquid biopsy and actually found out that, tepotinib or osimertinib, they act at both if the liquid or tissue is positive. So again, just to re-emphasize, if you are positive on liquid biopsy in a good standardized lab where the molecular pathologist showed, you can go ahead and treat. If it is negative, probably confirm it by tissue biopsy, send both of them together. That is what is there. Now, anybody by and large practices this. This I'll go to Vikas Talreja, very active in that. Vikas, so uh, now the Mariposa study has shown that people who lose their people who lose their EGFR mutations, they are the ones who will do better. People who do not lose, maybe you can use combination approach. Have you used it anytime in your practice? And if
For
yes, why?
selective
If no,
patients,
why?
yes. For selective patients, yes.
Okay.
Monitoring on specifically basis. Also, in terms of some of the one or two clinical trial where I work also helps in that. I do tend to get back to the because they tend to collect the EGFR data out of it, and they tend to we tend to discuss with them also. In clinical practice, I would say 1% of all patients, I advise 99%, but in a real applicability, 1% do tend to get it. I find it applicable.
Okay. I think this is where the science is going to move. Kripa, I will like to take your comments on this. I mean, to me, in the coming era, when combination approach is going to be a major concern in EGFR, which one to give only OC, which one to give Mariposa, which one to give Flora 2, to me, this is very, very apt. I think Prabhat Malik is running a trial based on this. But what are your comments on this? Do a EGFR liquid biopsy, maybe do it in 6 weeks, 8 weeks. People who do not clear, give them a combination approach. People who clear, give them a single agent osimertinib. To me, very scientifically sound. What do you say about this?
Absolutely. I think, even your RGCI data as well, the earlier one which you had published as well, I think that's there. So I absolutely agree with that. We're truly in the era of precision medicine and tailoring treatment according to treatment escalation and de-escalation based on the risk adapted strategies. So somebody who fails to clear the DNA, obviously ctDNA, obviously we know they have a poorer prognosis. One way of improving on that would be the treatment escalation approach for those patients. So I completely agreed on that.
So this is what exactly, this is not my data, but we have almost had a similar data. People who are molecularly responding will do much better than people who do not respond molecularly. And I do feel that a huge role is going to come for monitoring of this. Only thing is we need the science, we need the cost to come down actually behind it. This is all our data that Kripa was talking about. People who had a molecular response did much more better. People who did not have a molecular response actually did not do, and the overall survival was much better. P-value was very, very, very significant in this. We had only 42 patients in that actually. The third one basically is to determine early progression. So what happens, Dr. Animesh? How much time do I have, Rajat? Okay, Dr. Sham Agarwal is, what about co-mutations like P53 in the treatment selection? Can you take it, Dr. Kripa?
Yeah, so I think we're talking about co-mutations like P53 or even STK11, KEAP1 mutations, and so on and so forth. So we know that they're definitely prognostic, but would you actually use it for treatment selection? I think we're not yet there yet as far as treating patients based only on those co-mutations. But yes, definitely we know that they are likely to not respond as well, and also that the prognostically they're not probably they won't do as well. But are we there yet? We have the Revolver trial, which is looking at addressing this particular question of exon 21 L8 We are looking at whether the Flora data versus the relay data. It's a direct head-on-head comparison, looking at only exon 21 L8 data. So again, the question of co-mutations with either RB or P53 absolutely is being looked at. But as of right now, I think we're not yet in that era. I think all of us would agree that we're all in the era where we're going to look at doing combination therapies right up front. So I think I would stick to doing combinations, be it
To,
either
uh,
chemo plus
to
TKIs
answer
or
this, to answer this question from Dr. Sham Agarwal, sir, Mariposa trial did show that people who have a P53 concurrent mutation, the combination arm was doing much more better than that. But that is again a subset analysis. I think we need to have future trials. But to me, in my practice, if you have an L858R, if you have a co-mutation with P53, if you have a high volume of disease, if you have a brain disease, I counsel the patients for a combination approach. Having said that, combination approaches are difficult to tolerate. I mean, after giving so much of Flora 2 and everything, the skin toxicities in Mariposa and the nephrotoxicity and hematotoxicity in the Flora 2, it does. I think in the end we lose more patient, and patient says, Doctor, abhi aur chemo nahi lena hai. I'm a very much big proponent of probably a checkmate 9LA kind of a thing. Just give 2 cycles of chemotherapy, or maybe give and then start them on to early pemetrexed maintenance. But we need to have more trials on that actually. But yes, if somebody has a TP53 mutation, I would like to, really give that patient a combinatorial approach right now. To determine early progression, very, very important. Dr. Ankur, do you use liquid biopsy at progression or do you use tissue biopsy at progression?
Sir, in case patient is not going ahead with the repeat biopsy, I do prefer liquid biopsy in these sets of patients.
Again, very important, Dr. Pratik. We all speak of liquid biopsy, but to the best of my knowledge, till the time Guardant came with Infinity, they only also had a 74 gene liquid biopsy panel. Just because it's a liquid biopsy doesn't mean that we're doing a comprehensive whole exome, whole or CGP on that. Is it right? I mean, how difficult is it to make a panel on liquid biopsy? Is it cost effective? Dr. Pratik? Okay, I think we have lost him over there. Again, please look at the panel prior to that, except for Garden Infinity, which they have just come up now. And liquid biopsy is not good at picking up fusions. We need to, I mean, I am a sticker for tissue biopsy when there are, when there is a,
There is
progression.
especially a targetable biopsy site, like a new liver met, new lung lesion,
Correct.
which we can easily do a biopsy.
I totally agree with you, Ankur. I think we should be doing a biopsy. Send a complimentary liquid biopsy also, but do not discount tissue biopsy. Again, something comes on that positive, please go ahead and do that. So this is my answer. This is my last slide actually. So we initially start with this thing. A liquid biopsy at a diagnosis is including clinical usage as monitoring to predict response. It can be done, should be done. Various trials are looking at to determine early disease progression should be done ideally in conjunction with tissue biopsy. To determine MRD in early advanced stage, it's a research question, but a far-reaching implications that we have. So to summarize, what is the status of liquid biopsy? Will it replace tissue biopsy? No, it will be complementary to each other. You can love it or hate it, but you just cannot ignore this guy anymore now. And that I'm sure is for ChatGPT and Elon Musk and liquid biopsy over here. With this, thank you. Thank you all my panelists for a wonderful discussion. This went far better than what I thought. And hand it back to Rajat. Thank you. Thank you, Rajat, for the invitation.
Thank you so much, sir. As usual, a very nice panel discussion. I think everybody benefited. Along with me, I think everybody will agree that we learned a lot. Liquid biopsy certainly is there, but then there are more avenues that need to be discovered. Probably it may not still be adequate to replace it as a solid biopsy. Sir, yes, you want to?
Yeah, I just wanted to say I was hoping Dr. Shyam Agarwal will put on his video at that time. Sir, good afternoon.
हेलो
Your final sir Sunday को टाई पहन के हे भगवान मैं तो सर डिप्रेशन में
शादी
मर जाऊंगा आज
शादी में जाना
अच्छा फिर ठीक है सर मुझे टेंशन हो गई थी मुझे सर सर योर फाइनल कमेंट्स ऑन दिस सर
if you read my first comment,
जी सर
when you have the deep sequencing becoming available. So, why do patients relapse when we give them osimertinib? Is just because there are subclonal mutations existing in the same tumor, whether it is p53 or, MET, etc. So, which come up, once the EGFR clone is gone down. So, I think the future lies in discovering these subclonal mutations early. And then, as I said, I mean, as also you agreed that patients who have p53 in addition, they require a dual or, dual targeting or multi-targeting.
combinatorial
So I think we need to deep dive into the sequencing, make it more cheap, and therefore, you are able to take care of multiple mutations, maybe in a sequential fashion or in a, combination fashion in order to achieve long-term survivors like you are getting with CML. I mean, you have only one mutation there, and that is why patients don't escape. So in most of the solid tumors, we have multiple mutations, but we don't have drugs to target them. So, now, for example, amivantamab and lazertinib, I mean, the dual is better than FLAURA1 at least, or maybe at par with FLAURA2, in which you have combination of chemo. So you're talking of two things, I mean, you need additional therapies to target other mutations. So liquid biopsy is going to help us. But of course, you need more drugs to target those mutations. So I think that'll be my take.
and we need to have better understanding of the panels and we need to do as sir said deep sequencing and to get the cost down. That is very, very important. Dr. Bhavna ma'am is here. Ma'am, your comments too? And I'm just hijacking the moderation actually.
Sorry, is this a lung patient?
Yes, madam, it was a lung patient.
Actually, I'll be very honest. I'll
No
have
worry. No worries, ma'am. Hand it back to the organizers. Rajat.
Yeah,
So
thank
thank you
you.
so
Thank you
much
very
all the
much.
panelists and moderator. And so next session, this session sponsored by Roche, and I would like to invite Dr. Rajat Bajaj sir for the next session. So it's over to you, sir.
Yeah, thank you. Can I have the slides, please? So after this engaging panel discussion on the future of lung cancer, the CTC and the liquid biopsy, we talk about the role of immunotherapy in first-line metastatic NSCLC, and we're talking about atezolizumab. There are three trials that we'll be discussing. This session is sponsored by Roche. So the trials that we all know are IMPAR 110, next slide, 130 and 150. These are my disclaimers. Next slide. Next slide, please. So we all know that lung cancer is a cancer that we see very commonly in our practice, and the 5-year survival in stage 4 NSCLC over the years hasn't been that robust. With the coming in of driver mutations in selected few patients, things have improved, but then the wild type metastatic NSCLC patients have had a dismal survival at that till the time the advent of immunotherapy happened. Next slide. And immunotherapy first came post multiple lines and then was in the second line and then found its way eventually in the first line about 4 years back. Next slide. And then after that we have had multiple trials where the first line immunotherapy combinations have been tried, and atezolizumab also has been one such immunotherapy drug, the PDL1 inhibitor, where there are at least three trials of first line atezolizumab in metastatic NSCLC space. Next slide. So uh, the first trial that we are going to discuss is IMPAR 110. Next slide. IMPAR 110 was a trial where patients of metastatic NSCLC, EGFR and ALK wild type and treatment naive patients, they were randomized in first line space to receive either atezolizumab monotherapy or the standard of care treatment of chemotherapy. Next slide. Next slide, please. And these patients were having all histologies, that is squamous and non-squamous histologies combined. The choice of chemotherapy was histology based. Next slide, please. And if at all there was use of pemetrexed in the non-squamous, then the pemetrexed maintenance was allowed as per the Paramount study, with the primary endpoint being overall survival in the wild type population, and PFS and overall response rates being the secondary endpoints. So next slide. In this randomized phase 3 study, what came out is that patients, about one third of them had a high PDL1 expression, which was either a TC3 or a IC3, depending on the tumor cells or the immune cells score. The PDL1 clone which was used was SP142, which is normally the case with atezolizumab. Next slide. The baseline characteristics were well matched between both the arms, and we are talking about the segregation between a high PDL1 versus a low or a intermediate PDL1. Next slide. Most of these patients had happened to be non-squamous patients, and one could see that the overall survival improved by a delta of 6 months, which was the primary endpoint. And we are talking about the high PDL1 subgroup here, where patients had a median OS of about 20 months versus 14 months in the control arm of only chemotherapy. So it was a positive study with the significant p-value at 0.01. One can see the Kaplan-Meier curves separating early and very late separation also till the very end. Next slide. It was a hierarchical statistical design, so that also becomes important in the evaluation. Only a subset of patients who were never smokers did not benefit, but rest all of them benefited, is what is seen in the forest plot, which is available on the screen at present. Next slide. And after a continued follow-up, one can see that the OS continued to improve, and there is a good gap between the experimental and the control arm in the Kaplan-Meier curves with the hazard ratio of 0.76. Next slide. There were about 35% of patients in the control arm who received subsequent chemotherapy, and despite that, the benefit was maintained. Next slide. This is a graph to show that the OS hazard ratio more strongly favored atezolizumab versus chemotherapy after adjusting for the subsequent immunotherapy use as well. Next slide. And even if they checked with a high PDL1, according to the other clones which are available, like the 22C3 DACO platform or SP263, there also we found out that the benefit of atezo monotherapy was maintained. Next slide. Even the PFS was improved in favor of the experimental arm. Next slide. And again, the PFS was improved by a delta of about 2.5 months. Next slide. And the response rates were also higher, about 40% versus 25%. So this reaffirms the fact that if we have a high PDL1 score in patients who are having a metastatic NSCLC, EGFR and ALK mutation being negative, then these patients can be offered an atezolizumab monotherapy versus the standard chemotherapy that we use in histology specific process. Next slide. The safety profile was consistent with what we already know from a lot of other immunotherapy trials. The IRAs were there, but mostly they were grade 1 or 2 and they were manageable. Next slide, please. Next slide. So all in all, this trial was a positive trial with the primary endpoint of overall survival in the PDL1 high subgroup population being met. It was a study where it showed that there was a 6-month overall survival benefit of of the experimental arm of atezo mono compared to the control arm of only chemotherapy in a high PDL1 first line treatment naive metastatic NSCLC wild type population. The safety profile was also consistent with prior observations, so no alarming signals there. And all in all, this is the standard of care and a category 1 recommendation by NCCN in this particular space. Next slide. We go on to the next trial in this particular space, which is IMPAR 150, which was restricted to only the non-squamous population. Next slide, because there was use of bevacizumab, which was involved in this particular trial. So this is the trial schema, which shows that non-squamous population of stage 4 NSCLC patients where they were chemotherapy naive, randomized 1:1:1 to receive either a paclitaxel plus carboplatin plus bevacizumab, which is the control arm, followed by bevacizumab maintenance, or a ABCP regimen followed by atezo plus bev maintenance, or a atezo plus carboplatin plus paclitaxel combination with followed by atezo maintenance. So arm B and C were the arms which were actually tested and continued for a follow-up, and co-primary endpoints here were kept as PFS in the intention to treat population and OS in the intention to treat population. Again, importantly, there were patients, about 25% of them, who had liver metastasis. So a good disease burden patients were selected. Around 1,200 odd patients were there, and all of them had to be ALK and EGFR wild type. Next slide. About 7%, 7 to 8% were EGFR mutant or ALK rearranged that we would see in subsequent slides. There is a rationale of why atezolizumab should be combined with bevacizumab. It it tends to normalize the tumor vasculature, bevacizumab, so it results in an increased TIL ratio in the tumor microenvironment, and that is how there is efficient priming and activation of the T cell responses, and thus it restores the ability of immunotherapy to increase the anti-cancer immunity through the T cell mediated cancer cell killing process. Next slide. Like I said, that there were good number of patients who had baseline liver metastasis. There were about 7 to 10% patients who were EGFR mutant. mutant. Next slide. The overall survival was improved with the use of ABCP combination versus the paclitaxel, carboplatin, and BEV combination, about a delta of again about 5 months, with a hazard ratio of zero 0.8 and a p-value being significant at a median follow-up of 40 months. Next slide. Next slide, please. And if you look at the overall response rates and the duration of response, this also was improved in the intention to treat population. One can see that in the high PDL1 population, it reached up to 70%, and the intention to treat population, it was about 56% with the ABCP combination. Next slide. In the high PDL1 subgroup, there was a further improvement compared to the control arm in the experimental arm, with the overall survival being 30 months versus 15 months. Next slide. And if we talk about the low PDL1 expression patients, there was benefit was there, but it was minimal. Next slide. Talking about the key subgroups, that is the EGFR mutant and the liver metastasis patients. Next slide. One saw that EGFR mutation patients post first line use of TKIs also tended to benefit with a delta of about 3 to 4 months in the PFS. Next slide. So it tells us that this combination of ABCP can be a way forward in such patients where an EGFR mutation where an EGFR mutation is there and a EGFR inhibitor has been used in the first line. Next slide. The overall survival benefit was also there, and it was seen in this particular space of EGFR mutation patients. Next slide. Next slide, please. The overall response rates were about 70%, which is quite satisfying for a second line EGFR mutant NSCLC, where a first line EGFR inhibitor has been used. Next slide. In the liver metastasis subgroup, where there were high tumor burden disease patients, next slide, there also the so-called bad subgroup of patients had a benefit of the use of uh, this particular ABCP combination. Next slide, please. Next slide. So the addition of bevacizumab to atezolizumab plus chemotherapy did improve overall response rates and duration of response in patients with liver metastasis. Next slide. And patients who had a bulky disease, and it was according to the quartile that they really segregated these patients who were included in this particular trial. They saw that next slide, these patients also did benefit. So probably if we have to use this combination of ABCP, it is for patients who are bad subgroup of patients because of the sheer bulk of disease, because of the liver metastasis, or because of the some driver mutations for which the first line actionable targeted therapies have already been offered. Next slide. Next slide, please. The safety signals were again similar to what we already knew from the other trials. Next slide, please. The bevacizumab related proteinuria and hypertension were there, but it was not something which led to treatment discontinuations. So hence it is a regimen which can be used and is relatively well tolerated. Next slide. Now talking about the last trial, which is the IMPAR 130 non-squamous population. Next slide. So this is the use of a combination of immunotherapy plus chemotherapy. Not only will we have patients who would have a high PD-L1 expression, but then there would be patients who would have a PD-L1 which is either intermediate or low expression. Next slide. So they took patients who were having all category of PD-L1, that is intention to treat population, and combined combined atezolizumab with chemotherapy. Next slide. And the chemotherapy that they used was nab-paclitaxel plus carboplatin. And the reason for that was that there was a uh, steroid sparing effect of nab-paclitaxel, and we do not really want to give steroids with immunotherapy. Next slide. And later patients were allowed to use pemetrexed as maintenance as it was a non-squamous population. These are the baseline characteristics, and we see that there were about 15 to 20% patients in both arms which are having liver metastasis. Most of the patients had a previous history of tobacco use, and about 20% had a high PD-L1 expression. Next slide. So the primary endpoint of this particular study, which was the PFS and the OS, they were met. One can see that the PFS was 7 months versus 5.5 months. Next slide. And the overall survival also was improved, and the 2-year OS was 40% versus 30%, and the median OS was 19 months versus 13.5 months with a p-value of 0.03. Next slide. So both PFS and OS were improved, and this is a forest plot to show that almost all the subgroups they benefited, and the diamond was at the side of experimental arm with the combination of atezo plus chemotherapy. Next slide. Next slide, please. Next slide. Overall response rates were also improved with this combination, reaching up to about 45%. Next slide, please. These are the adverse effects that are similar to the other trials of immunotherapy. Next slide. So to conclude, IMPAR 130 was a positive study, and irrespective of PDL1 expression, this particular combination improved the OS and PFS of the patients who had this combination use of immunotherapy plus chemotherapy versus chemotherapy alone. And the steroid sparing effect of nab-paclitaxel carboplatin can be brought into effect in this space where many a times we have patients where pemetrexed cannot be used because of either the steroids not being allowed for some reason, or patients having a borderline KFT where pemetrexed cannot be used in creatinine clearance less than 45. So I think this particular combination has its good space, and as clinicians, we have to resort to this combination to give the best to our patients. So with this, I thank you all for your patient listening. So I think we can move ahead now. So after this talk on first line metastatic NSCLC and the role of immunotherapy there, we go on to the panel discussion, and we are going on to breast cancer now. This panel discussion is going to be on the decision-making strategies that we have to approach in 2025 for managing a metastatic triple negative breast cancer patient. And to talk about that, we have with us Dr. Sham Agarwal, sir, who's a well-known medical oncologist in our country. Sir, good morning. Sir happens to be the director of medical oncology at the Gangaram Hospital in New Delhi. Sir, can I call the panelists, please?
Yeah, please do. Yeah, sure.
Yeah, thank you. So, Dr. Neeti Raizada, ma'am, is she there?
Yes. Hi, Rajat. Good
Hello,
morning,
ma'am.
everyone.
So, ma'am is the medical oncologist and the senior director from Fortis Hospital, Bangalore. Dr. Bhavna Sirohi, ma'am, is there. Good morning.
Good morning.
So, ma'am is the medical director and senior medical oncologist at the Balco Center in Raipur. Dr. Sohail is there. Dr. Sohail Qureshi.
No,
I
sir,
think
he is not there.
he's not there. Dr. Pankaj Goel is there.
Yes.
Dr. Pankaj is a consultant medical oncologist at RGCI. Dr. Seema Gulia, she is the senior consultant and chairperson of Department of Biochemistry in Gangaram. And Dr. Anbarsan, who's a medical oncologist. Uh, I think he is also joined. Gitika, can you please confirm?
So Dr. Anand Singh Shekhar sir is joined, sir.
Okay. So I think everybody is there apart from Dr. Sohail, who couldn't join because he
Right.
was unwell. So rest everybody is there. So over to you, sir.
Right. So thank you, Rajat, and thanks to all the panelists. So let me correct. Dr. Seema Gulia is the professor of medical oncology at the Tata Memorial Hospital, and I welcome all the panelists to be here. It's an elite panel. So, and the discussion topic, as you see here, is the metastatic triple negative breast cancer. So, unlike HR positive and HER2 positive, TNBC has seen few advances, which I think we can discuss as a case-based panel discussion. So I think I've just made it very simple. This is a 46-year-old female who was diagnosed about 2 years ago with locally advanced TNBC, and then she was treated with neoadjuvant chemo and pembro as per the current guidelines. Subsequent to the chemo, she was operated, irradiated, and was also given adjuvant pembro. So I thought I'll put this here because this is what I believe most of us are doing in our day-to-day practice who can afford. So, Dr. Neeti, is this the correct approach these days?
Yeah, sir.
Right. So
That's
anybody,
what we do. Yeah.
so I think we are all following this if somebody can afford pembrolizumab.
But
Right.
Dr. Sham, we would also do, I'm assuming this lady is germline BRCA negative.
Right. Yeah. We're coming to that. So, okay. So germline has become important, especially for patients who are locally advanced, and one would like to perhaps use, depending upon the response, the role of olaparib. So I think since the focus is on TNBC metastatic, so this lady relapsed 2 years down the line in lung and liver, and she has a good performance status, and the hematology and the biochemistry is all right. So, Dr. Pankaj, are you there?
Yes, sir.
So, what next? Next slide, please.
Sir, I'll like to do a biopsy.
Okay, and what do you want to look for in the biopsy?
So I want to make sure it's still that TNBC, nothing has changed. And it's been 2 years. I would like check CPS score also. If it is turns out to be TNBC, then of course patient becomes a candidate for pembrolizumab again, since 2 years have lapsed between. So I'll treat it as first line. And
Okay.
BRCA, of course, what madam has just told, that also we will need to do.
Right. So, anybody has a different thought? Dr. Shekhar, has he joined? Dr. Seema, Dr. Seema Gulia?
Yes, sir. Sir, I agree with the sir that we will repeat a biopsy and we would like to reconfirm that it is still TNBC. And also, I would also want to look at what is the HER2 status, whether it is HER2 low, 1 plus, 2 plus, that also I would want to look at.
Perfect. Anybody for, NGS at this point in time? Because it's in fashion and, I mean,
Right.
Dr. Bhavna, so you are the expert on NGS and
No, I'm not, Dr. Sham. It's basically, yes, I would do NGS because triple negative breast cancer we know has very poor outcomes.
There is some role for germline PAL-BT also, sir. Recent data showing that there is 70% response rate for person
Yeah.
who are having germline PAL-BT also. So that
We
also I
should
would
do
like
a
to look at.
multi-gene germline panel. Yeah.
Germline.
so you would like to do the HRR. So Shekhar, you agree with the NGS at this time? I mean,
Yes, sir. Multi-gene NGS at this time, yes, sir. At least for germline.
at least for germline, not for the somatic ones.
Somatic. Yes, sir. Because there is a good amount of data we are getting for uh, NO2 in the space of low HER2 setting. So I would like to explore the option before that. And if it is negative, then only I will proceed with the NGS. Sir.
One could argue against it also, Dr. Sham, if we have a good first line option, if the lady is PDL1 positive, germline BRCA, then we can reserve NGS for later, because it's always better to do NGS on the metastasis if possible. So one can argue against it, especially if we have drugs which have a survival benefit.
And the response rate with somatic BRCA1, BRCA2 is also close to 40% only, sir. It's not that great. So we can reserve it for later line, sir.
Okay, so a lot of things have been spoken here. So are you going to do, germline, analysis for HRR genes, or are we looking at somatic HRR genes or BRCA1, 2? I mean, Dr. Sekhar, so when you're sending it for NGS, so it would include the BRCA1, BRCA2, right?
Yeah.
Yes, sir. It includes BRCA1 and 2, sir.
Right, Bhavna?
Yes, absolutely. Yeah.
So, Dr. Neeti, your thoughts on NGS and all
So
the
the standard is 22C3 PDL1 and germline BRCA and PAL-B2. But I would still, I mean, I'm just putting up an argument that why don't we have a fresh tissue and we can just do tissue NGS, where if the VAF is very high, we already know that the patient may have germline mutation of the same. And plus we'll have more information. So we can have a plan of first line, second line, third line ready if we have good tissue and the opportunity, finances are okay and patient is willing to do.
Okay, so we heard everyone. So we want to know about the CPS. We want to know about the HER2 status. We want to know about the HRR genes, including PALB2, and maybe more information on other somatic genes. Next slide. So a repeat biopsy was done. Next slide. BRCA testing, I think we already discussed. Next. So I think we did cover NGS tissue or liquid. I think tissue would be preferred at this time. Next. So that's the outcome of this particular patient report. CPS, this continues to be triple negative. CPS is 30%. BRCA1 is pathogenic. HER2 new 1 plus, and NGS shows NTRK positive report. So, Dr. Neeti, I mean, this patient, had 2 years ago immunotherapy or pembro. So, what to do now for this lady who is good performance status, 48 years old, and has lung and liver mets?
So visceral disease, I would still consider single agent chemo along with IO, maybe PEM with NAP-PACLI or PEM with PACLI. And if at all she's extremely fit and I really want to make sure the tumor burden is very high, I could possibly use dual chemo agent, but single will be as good. And reserve the other options for later on. Maybe subsequently I can use PARP inhibitors. And NGS, when I see an NTRK positive disease, first I'll have a discussion with my molecular oncologist whether this NTRK is kind of significant or not. Because I mean, we have had 3 patients recently, and when we had a discussion, they said, well, this is not an actionable mutation. But at the same time, if BRCA and NTRK both are positive, I'll keep NTRK for reserve later on.
Okay, great. So, Dr. Bhavna, your thoughts on how to manage this individual, single drug versus dual chemo or immuno?
So the TNT trial compared just carbo versus docetaxel and the anti-TUD did. So my usual preference is just carbo with pembro or gem carbo because she's a young lady, so we want to avoid hair loss. And that would be my standard first line. Second line, again.
We'll come to that. So let's focus on first, right? Dr. Seema, so this patient is BRCA, pathogenic.
Yeah.
So the choice of chemo.
So the choice, I mean, I would like to differ here that because this patient has already received immunotherapy. She is not immunotherapy naive, though she has relapsed after 2 years.
Right.
So we do not have a strong data of using IO after IO. That data, that is still the question. If we look at Olympia trial, patients who received olaparib in first line setting, they had a survival benefit, though the overall trial was negative. So if the patient disease burden is not significant, I would prefer to use olaparib in the first line setting. and maybe later on we can discuss other options.
Okay, so the issue is, yeah, I agree in principle that patients who were given Pembro along with chemo in first line were never exposed to Pembro. So that was the idea of putting that issue, that now that our patients are going to be receiving Pembro, and if there is a gap of more than a year or 2 years, should it, okay, let me put it the other way, Seema.
There are some data for you rechallenge immunotherapy when they use single agent immunotherapy followed by double agent immunotherapy, where the response rate is only 20 to 30%, sir. So, but in breast cancer, we have good number of options, and she is only she had a very good DFI. In this scenario, as Seema ma'am suggested, if there is no visceral crisis, I prefer to give single agent olaparib also, because as a first line, when we use earlier olaparib, it will have better response rate. And if
Second,
patient
let
is
me
having
put it
second
this way.
disease, I
Let
go
me put
to
it. This patient, is all negative. BRCA is negative. HER2 is negative. There's nothing else targetable. So now this patient is relapsed after a couple of years. Would you use Pembro then as a first line?
Yes,
if
sir. Then I
then
would
okay.
prefer
Yes, sir.
Pembro, because if she's HER2 negative and she's BRCA also negative, then we can re-challenge with Pembro, because if we look at the Impassion 132 trials, that included patients who relapsed within 1 year and there was no benefit of IO. So patients who progressed more than 1 year after the receiving of first line therapy, and this did not include immunotherapy, they had shown benefit with adding IO. So I mean, it is just an extrapolation of data from other trials, but given the fact that she has relapsed after 2 years, using IO is a reasonable option
Right.
in
Right.
presence of BRCA1 negativity.
So I think Pankaj did say earlier that he will treat this lady with IU as a fresh case. Pankaj,
Yes, sir.
you stick to that, or you after
Yes,
listening?
sir. No, I stick to that.
Okay, so there is a
Sir,
little,
one
But
opinion I would
Sham,
like to take
even
here, sir.
I would stick to that. The reason being, I think even Impassion 132 showed that, people who were more than 12 months of DFI and all the other subset analysis as well. If the DFI is more than 12 months, there is benefit of IO. And the keynote study showed that the survival benefit in CPS more than 10. This lady has 30. Was quite significant with an overall survival benefit. And the use of olaparib earlier on, Dr. Seema, is a very small subset analysis. So I would go with something which has shown a survival benefit. So I would stick to IO.
Yes, ma'am. I mean, both the options are reasonable. I completely agree with you. But if we look at the data on ovarian cancer trial, there also olaparib was most effective when used in earlier lines of therapy rather than later lines of therapy.
Okay.
right.
Then
So
if we anyway use this in first line olaparib, I don't think we'll have any chance to use IO later on.
Or platinum, because
Yeah,
there is data that if you use platinum after olaparib, there is very little benefit. In fact, if I've used olaparib, I give something else and then come back to platinum if I get a chance in third line or fourth line. So platinum for me is very, very important here, whether plus or minus Pembro.
correct. So there's a debate I see here, and Dr. Neeti, I mean,
Yeah, so actually, as I said, I would consider immuno plus chemo in this setting and wait for olaparib to be used subsequently.
I think currently it seems that 3 out of 5 are in favor of IO and chemo, and a platinum, would be preferred over a taxane. So you said NAP-ACLI, Dr. Neeti. Do you still stick to that?
Yeah, so but again, I mean, it depends. I mean, Gemcite cisplatin is also a very good option because BRCA positive along with Pembro. So, or carboplatin.
I would reserve taxane sequentially, Niti, later on, because that's an amazing option for a breast cancer patient rather than combining it.
No, the way
sequentially.
your thought process is right, but what I think is you exhaust one option and then go to the next.
Yes.
So, gem platinum, I would possibly, And that's probably the reason I would re-challenge with IO and then think of other options later on.
Absolutely. Yeah.
Okay, so let's move on to the next slide, please. So next slide, I think we have answered a few questions already, in this discussion as to what should be the first line and the second line. I mean, organizers, please, can you move the slide? So I think next slide, please. So I think this is a small, the data from the Keynote 355. Next slide, which, used the combination of pembro and chemo. And we saw and especially, so you need to have the, CPS more than 10 in order for the chemo and pembro to be effective or to be used, and which showed a PFS and OS advantage. Next slide. Next. So, this patient got carbo, gem, pembro, and did well for 10 months and then relapsed again, and she still continues to be in good health. So I think everybody agreed on olaparib. Dr. Sekhar, next slide.
Yes, sir.
Yeah, so this
Sir, yes, sir. And I will assess the relapse, how bad the relapse is, and whether she is having visceral crisis, which is significant or not. Because if she is having significant disease volume, at this point of time, I may consider for NR2, sir, if the disease volume is very high. If the disease volume is not that high, then I consider for olaparib for it.
Right. So, Dr. Bhavna, patient is still well preserved and has a good, hematological and biochemistry profile.
I'd go with olaparib, second line, and reserve the ADCs for later.
Great. So I think there seems to be a consensus after the use of pembro and chemo. Next slide, please. I think somebody did address this issue of PALB2 because of although it's not perhaps approved, but then Dr. Seema, will you, use olaparib for PALB2?
Yes, so there is phase 2 data on the response rate of olaparib in germline PALB2, where the responses are seen up to 70 to 80%. So I would consider olaparib for germline PALB2 mutation.
Pankaj?
Yes, sir, I do agree.
Okay, so I think there is agreement here. So the next few slides, maybe they're showing some data there. So I think this is, of course, an old slide, but here everybody with the metastatic tumors has to undergo BRCA testing and including the PALB2 as well. Next slide. I think this is what was being referred to. The PFS advantage and the hazard ratio, even with talazoparib, is good. Next slide. And this, I think, was being referred to by Dr. Seema, that in first line MBC, there is an OS advantage. Next slide. Yeah, I think the side effects anybody wants to highlight, because we're using a lot of olaparib. Dr. Neeti, any experience with the development of MDS or AML?
No, sir, I think this is in the metastatic settings. So I think the profile or the interaction or the exposure to PARP inhibitor is not as long. But anemia, what I have noticed is that there are patients who would not have anemia at all, but the patients who would have anemia would probably have it very early, within the first 3 to 4 weeks.
Right.
And of course, grade 3, grade 4 anemia is seen very often and requiring transfusions. But since it is metastatic, I don't think we see very often AML or MDS. But in other settings, yes, we need to watch out for.
Anybody has seen MDS, AML? I've seen one or two.
Sir, we have seen in couple of patients who are treated for ovarian cancer settings, sir.
Yes.
And this risk of MDS is very high when the patient has received multiple lines of chemotherapy.
Right.
And on top of it raising, it is more of a cumulative effect, sir, rather than olaparib alone as a contributory factor.
Exposure to the previous lines of chemo drugs. Next slide. So I think this is some data on PALB2. Next slide. That shows 82% response rate with olaparib. So that's the reason for next, please. Okay, the same thing here. Next slide. So this patient now develops brain mets. So where do we go from here, Pankaj?
Yes, sir.
So patient is symptomatic with headache and has multiple, lesions in the brain.
So radiation. So
Okay,
we'll take a radiation opinion.
radiation
And then for systemic therapy, I need to do the biopsy again from somewhere to see whether it's low positive or it's zero.
yeah, we mentioned it was HER2 1 plus.
1 plus.
So in that case, sir, I'll be more keen in using this HER2.
So you're keen on using NHER2. Dr. Bhavna, please.
So I'd probably go for sacituzumab govitecan if
Uh-huh.
finances are not an issue or just plain
Yeah,
kit.
everything is available, yes.
Yeah, so sacituzumab govitecan would be my choice.
So why not NHER2?
Because I think the data is more towards HER2 positive, the robust data. HER2 low, yes, this is an option that can be used. And there was this data that if they used TXD after sacituzumab govitecan, I think it was probably better. I know the numbers were very small. So in triple negative, I think my first choice would be sacituzumab govitecan and then trastuzumab deruxtecan, because that also remains an option down the line.
Right. So you said sacituzumab followed by TDXD, right?
Yeah, yeah.
Okay, Dr. Neeti? Or Dr. Neeti is not there. Dr. Seema, please.
Yes, I agree with Dr. Bhavna that because she is only HER2 1 plus, so I would use sacituzumab govitecan first line and then HER2, because in HER2 2 plus the data is more stronger for HER2 compared to 1 plus.
Yeah.
Shekhar?
Sir, here the concern mainly with the platform in which we are doing the HER2 testing, sir. Most of the time, our pathologists are not in coherence because the platform used for the NR2 in the Destiny trial is different from what the platform we are using currently. That's why they are little bit hesitant to use in 1 plus, or even they are hesitant to report low HER2, ultra low HER2 setting in this time being, sir. So as I agree with the both panelists like Seema ma'am and Bhavna ma'am, I go with sacituzumab govitecan if available. Later on, I will consider TDXD or Datoderistin also. Upcoming data is coming for Datoderistin also, sir.
Shamsa, I actually agree with everybody that yes, I would use sacituzumab prior to TDXD. And of course, I will also look whether there's symptomatic brain disease and systemic recurrence. If sacituzumab is not available, actually there is small data with PARP inhibitor along with temozolomide that can be given, especially in resource deplete setting or resource restricted setting in which we are looking for option and we cannot procure sacituzumab.
Okay, so I'll just show you some data on sacituzumab and TDXD, which looks almost at par, when it comes to, although, I mean, they are different trials. So next slide. Okay, next slide. So I think these are the, patients who had failed on early lines of therapy. I mean, next slide. When compared with the standard of care, SASI was better. And this is the PFS advantage in general, not talking of brain. This is without brain, actually. Next slide. And this is the overall survival advantage. So next slide. So that's the TDXD. Again, you see the hazard ratio is robust for HER2 low, which the next slide shows, I think, data on TNBC. Next slide. So there were very few patients in this, Destiny 4 study. 40, on TDXD, and the rest 18 were physician choice. And you can see, a good curve in favor of TDXD. Next slide. So if you look at the responses, the water plot, looks kind of similar, indicating the efficacy. Next slide. Okay, so I think by and large, both the drugs have the potential of crossing the blood-brain barrier, and if you look at the subset analysis with sacituzumab, the hazard ratio is not that robust for patients who have brain metastasis, and that's also a subset analysis. So, but then I agree with all the panelists here that either of the drug can be used and then sequenced. So in the light of this new data, SASI is being combined with Pembro and looked upon for patients who are PDL1 positive. Next. and even for PDL1 negative, people are trying to do in the first line. So, looking at the data for the ADC, this is being compared in these studies. Next slide. Okay, so I think we've covered a few things here. So what about these other areas like androgen receptor or, tumor mutation burden and re-challenge with immune checkpoint inhibitor? So Dr. Neeti, do you look at these, in your practice in a young fit patient who has survived, 2 or 3 lines of, and of course we do have several other chemo options like eribulin and capecitabine, etc. So what do you think about the role of androgen receptor and TMB?
So there is a very promising role of all of that. TMB although has limited data, but then yes, if you are using larger NGS panel like Guardant Infinity or something, we'll always get all these information. And AR subset will generally be the good subset who may benefit for anti-androgen, but AR is not by IHC. In that case, we need an NGS too.
Right. So AR is a simple IHC test. Dr. Seema, do we?
So there is data which says that AR by IHC may not establish therapeutic value. And so when we are doing larger NGS panel and then we see AR expression, that may be more useful.
More relevant. Dr. Seema, any comments on, these issues?
Yes, sir. AR, all patient doesn't need AR testing by IHC, and we are routinely testing AR by IHC. So patients who have luminal type subtype, those who have predominantly nodal metastasis, bone metastasis, and do not have a significant visceral burden, in those patients we definitely test for AR. And in few patients we have used anti-androgen therapy, and we have seen occasional complete responses too with that. So that is one of the important area which can be looked at, and patient, this is an important armamentarium that can be considered in patient who fulfills those criteria. And the by IHC, the positive should be more than 30%, that, and it has to be strong positivity. Re-challenge with immune checkpoint inhibitor is we have to decide on case to case basis. It is still an important area of research, and rest has already been spoken about.
Dr. Sekhar, your thoughts? Sequencing, we've covered a few things here.
Yes.
Yeah.
Yes, sir. I definitely looking into the prospect of NTRK because of the availability of entrectinib in Indian market. And apart from this, there are also upcoming data for methylation fraction with Garden Infinity. They are also doing with that, sir. And one more thing is AA is also upcoming. With the amount of AA coming into the picture, the PDL1 assessment and HER2 assessment going to have a bigger change, sir. And think they are also planning to get a PDL1 assessment. Maybe in future, we get more of AI related PDL1 reporting, HER2 reporting. This will change the treatment dynamics with this respect to the area also.
Okay. Pankaj?
So I think they have already covered. There's nothing new to add.
Okay. Dr. Bhavna, please.
I agree with everyone. I haven't seen a single NTRK patient in breast yet, but I've had colleagues who've had it, and they've had good success with entrectinib. TMB, not so much of a good thing in breast, haven't had much good results. AR, I do test by IHC. As Seema said, especially in those with predominantly nodal disease, and have had some fantastic responses with enzalutamide.
Okay, so can we have the next slide and we can, close this by just. So I think this is some data on TMB, which is more than 10, not, specific for breast, but I think people are, using either Pembro or the IOIO, which was talked about for patients who have a tumor mutation burden than 10. Next slide. So this is about, I think this Dr. Seema did say that if the, AR is more than 10%, you can get some good responses with drugs like enzalutamide or, abiraterone. So it should be kept in mind. Next slide. So I think this is a sort of a summary slide, which covers up, the first line, second line, third line, and beyond. And so not only NTRK, but MSI, which I think is being routinely done, RET, and we also covered TMB, should be, kept in mind. So I think I think we've covered all these areas, although, I mean, the options have increased and they're likely to, perhaps get better once we have more agents for targeting, because these are some of the, actionable targets, like, this is for breast cancer, of course, like FGFR1, or, I mean, this covers the whole breast cancer gamut, not just restricted to TNBC. Next slide. Yeah, so I think this is the last slide, I would say, that, in the second line, we have sacituzumab, TDXT, for, PALB and BRCA, we have olaparib. Pembro, we've already covered, and these are the other sort of genes and the ADCs which are going to be available. So I think we have overshot our time, and I thank all the, panelists for this interactive discussion. So thank you, Rajat, for giving us this opportunity to get together. Thank you very much. Thank you.
Thank you, Raksham. Thank you.
Thank
Thank
you,
you.
sir.
Thank you very much, everyone. I thank Dr. Shyam Agarwal, sir, and all the panelists to join in on this Sunday and discuss the management of advanced triple negative breast cancer. Really appreciate the inputs from everybody, and thank Dr. Agarwal, sir, once again for this lively interaction and discussion. So now we move ahead, and this is going to be the last talk of the day, and we are going to talk about the role of transforming the paradigm of HER2 positive breast cancer treatment, the flexible future. And to discuss this, we have with us Dr. Manish Singhal, sir, from Apollo Hospital, who is going to take us through the role of FESGO in the management of HER2 positive breast cancer. Over to you, sir.
We cannot hear you.
Technical team, can you please check? Dr. Manish sir is not able to, he's not audible actually.
Ma'am, actually, he will connect the mic.
So, am I audible?
Yes, sir.
Yes, sir, you're.
So, I have to do it from my mobile phone because I think there's some technical glitch. So, thanks all. And this is about the impact of subcutaneous dual HER2 blockade on patients of HER2 positive breast cancer. Next slide. This is the disclaimer slide. Next slide. So we know that achieving a PCR with neoadjuvant chemotherapy has resulted into survival benefit, and in almost all breast cancer subtypes, mainly the HER2 positive and the triple negative breast cancer subtypes. Next slide. So the neoadjuvant treatment with in HER2 positive breast cancer with a double blockade, which is called as the horizontal blockade, and with chemotherapy resulted in higher achievement of PCR rates versus using only single blockade. And this PCR rates have been in the tune of 55% to almost 80% in various studies, depending on the ER positivity versus the ER negativity with HER2 positivity. Next slide. And patients who achieve a pathological CR has an improved event-free survival compared with those who do not achieve, and this is more true when you receive a double blockade as compared to a single blockade. So a double blockade of the HER2 target has become one of the standard of care now. Next slide. So this is a pooled analysis of the event-free survival for patients who achieve a pathological complete response. Next slide. So regardless, not only this, those patients who do not even achieve a PCR, they also tend to have a better event-free survival than those patients with patients who receive a double blockade as compared to a single blockade. Next slide. So in short, not only does the patient chances of achieving a pathological CR increases when using a double blockade, even if they do not achieve a pathological CR, their event-free survival is still better if they receive a double blockade. Not only this, adverse events are also quite similar. That means you don't add to the toxicity by using a double blockade of the HER2 target as compared to a single blockade. So without adding to the toxicity, you end up achieving a better PCR and also a better event-free survival, irrespective of the PCR rates. Next slide. So event-free survival, disease-free survival, overall survival are all supportive of achieving a pathological CR and suggest that a clinically meaningful improvement occurs while using a double blockade as compared to a single blockade without adding any adverse events. Next slide. Now coming to the current status of the double blockade. Next slide. Next slide. Yeah. So this is also in keeping with the standard current guidelines. The preoperative or even the adjuvant guidelines dictate that a patient should receive a dual HER2 blockade, and this should be carried on in the adjuvant setting also, and that is based on the affinity study, especially patients who have a node positive disease. Next slide. And as I said that in the node positive, the delta of event-free survival improvement is about 4.5%, and this should be carried on in the adjuvant setting as well. Next slide. And not only this, those patients who have metastatic disease, even there, the data is very clear that there is improvement in overall survival by the use of dual blockade as compared to a singular blockade, and that comes from the Cleopatra study. Next slide. However, so this is in keeping with the ISMO guidelines as well as the NCCN guidelines. Next slide. So the process of receiving an IV therapy and dose calculations places a significant burden on the entire life of a HER2 positive breast cancer patient, especially in a metastatic setting when they have to come for several years or several months to receive this therapy. And this, therefore, there is definitely a logistical and time burden, physical pain and discomfort. It requires a lot of support system because you have to come to the hospital with an attendant. There's also a lot of emotional impact. So this results into overall experience of burden or significant burden while receiving an IV therapy. Next slide. Therefore, there is an ardent need, or there was an ardent need to substitute the IV with a subcutaneous formulation. And this can ease the burden, not only ease the burden of the emotional support, but also ease the financial support for receiving a subcutaneous therapy. Next slide. So an IV therapy, we know that takes long time, and it's practically the entire day, which may be taken to receive this IV formulation therapy of pertuzumab and trastuzumab, and it requires a lot of waiting time. There's a cannula insertion, central access, so and so forth, and this is like practically the entire day gone. Next slide. So with this background of increased anxiety, frustration, guilt, and isolation, which is associated with IV therapy. A subcutaneous formulation has been devised, which is available in the form of Phesgo. Next slide. Next slide, please. So this is the repetition of the same previous slides. Next slide. So Phesgo is the first formulation in oncology which has two monoclonal antibodies in fixed dose formulation, and it is formulated with recombinant human hyaluronidase to allow subcutaneous administration of a higher drug volume, which is almost about 15 ml as a loading dose and 10 ml as a maintenance dose. It's a ready-to-use fixed dose formulation and a subcutaneous formulation which takes about 5 to 8 minutes to administer. Next slide. So this has gone through various studies. So Frederica being the registration trial, which showed non-inferiority of the Phesgo formulation versus the IV formulation at cycle 7 in achieving the C trough levels. The pathological CR rates were very similar, around 55% in both the arms. Not only this, the Fonseca study, which was the patient preference for Phesgo versus the IV formulation, showed that 85% patients, and not only patients, the healthcare professionals also preferred the subcutaneous formulation over the IV formulation. After long-term follow-up, the efficacy data showed that there was slight but higher event-free survival or the invasive disease-free survival and overall survival in favor of the Phesgo arm. Next slide. So it basically takes two innovative molecules in one single dual blockade, a single shot, and there's no dose calculation, there's no chance of dosing errors, etc. Even with the changing weight of the patient, which many of our breast cancer patients, they keep changing weight, and you have to recalculate the dose of trastuzumab every time. So there's no dosing error, and this is one shot treatment, and it can be done in an OPD basis also. Next slide. As far as the toxicities are concerned, the toxicity is very similar between the two arms. As a matter of fact, there seems to be slightly lesser diarrhea and slightly lesser cardiac events also with Phesgo as compared to the IV formulation. Next slide. And this is irrespective of the weight of the patient or the weight quartile. The side effect profile does not really change even for the lower weight as well as the higher weight. And irrespective of the body weight, the adverse events remain similar. Next slide. So all in all, there is patient preference. There is also less emotional distress, more time to life, which is achieved by using a subcutaneous formulation as compared to an IV formulation. And this has been consistent with the PrEF-HER study as well. Next slide. So overall improvement is there in treatment efficiencies as well, as more healthcare professionals as well as patients prefer the subcutaneous formulation as compared to the IV formulation. Next slide. So 66% patients, which eliminated the cannula concerns, preferred the subcutaneous formulation as compared to the IV formulation. Next slide. Not only this is cost effective also, the HER2 targeted therapy, because in various methods which has been used, you get the trastuzumab totally free of cost in the same fixed dose combination as compared to taking the drug separately. And of course, it saves on the duration of treatment, less pressure on the beds, and shorter administration time. So overall, this becomes a cost-effective therapy also. Next slide. So dual HER2 targeted therapy with the fixed dose combination is a cost-effective treatment strategy, which is not only preferred by healthcare professionals, but also by patients, and achieves the same aim of achieving pathological CR or the C trough levels or event-free survival and overall survival as well. Next slide. So to conclude, neoadjuvant treatment with fixed dose combination is a cost-effective strategy for managing patients with high risk HER2 positive early breast cancer. Adjuvant continuation of fixed dose combination dominates all strategies, and these additional costs are generally low relative to the clinical benefits which are obtained. Next slide. And this is the new assistance program wherein the patients tend to pay only for 5 paid vials in the first year, and thereafter they get another in the second year. They again pay the 5 vials in case they have a metastatic disease, and then lifetime free. I think with this particular strategy, the Phesgo formulation is not only a patient preferred formulation, but is cost effective and may also be able to beat the cost of generics which are available. Next slide. So this is the tagline for the Phesgo. This is free from lines, far away from fear, with subcutaneous dual HER2 blockade. Thank you.
Thank you, sir, for an excellent talk. And thank you for joining on this Sunday morning. Thanks, everyone, for joining on this Sunday morning. Thanks to my colleague, Gitika, Dhruv, and Swarangi. Thanks to the tech support, and thanks to the pharma colleagues. Thanks to Roche, Prismis Kavi, Eris, Dr. Reddy, Selgin, and Merck. Thank you, everyone. Good afternoon.